Committee Room 29. Sound. 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 Committee Room 29, 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 Sound. Committee Room 29. 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 Sound. Committee Room 29, 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 sound.
Okay, so an overview of today's business. Today we've got an oral briefing from The Department on Stroke Action Plan. We have an oral briefing from Royal College of Emergency Medicine, and we have a commencement order SR and 2 written briefings from the Department. We're going to start in public session and declare the meeting open to the public. And just to advise members that the committee meeting will be recorded and broadcast throughout Parliament buildings and online. And to advise those in the public gallery, they are welcome to use mobile devices as long as they're in aeroplane mode, and all devices are muted. They can connect to Assembly Wi-Fi. Password details are available on the gallery rules, and it is not permitted to take photographs or to record any of the meeting. Apologies. I have an apology from the Chair, Philip McGuigan. Anybody else? Any other apologies? Take that as a no. Was there anybody else coming in online, or?
Not that we're aware of.
Okay. So item number 2 then, Chairperson's Business. Members, last week I attended the North-South Interparliamentary Association where one of the topics discussed was palliative care. This was a discussion in relation to joint working, particularly in relation to children's services. If members are content, I would suggest that we write to the Minister and the Minister for Health in the Republic of Ireland to discuss what engagement there has been on joint working for children's palliative care services. Is everybody happy enough that we progress that?
So in doing that, palliative care services are a huge issue. We also have a massive issue with palliative care services at the Children's Hospice and the actual sustainability of the Children's Hospice. And last week the Minister gave 500,000 because of the precarious nature of the finances around the Children's Hospice. I think we should also include in our discussion the sustainability of children's services for palliative care, and particularly focus down in on the hospice. And I suppose the second thing that sorry Chair, but I'm quite passionate about this. I think it's really important, is that transition period. What work are the Department actually doing on the transition period where children are no longer eligible for children's services, but sometimes adult services don't accept them, and particularly in a community setting, that leaves confusion as to who actually looks after this young person who is in palliative care. And I have an active example of that. I'm not going to discuss it here, but that is very, very real, and at the most vulnerable time in a young person's life, that is not a conversation that we should be wrangling over.
No, absolutely not. I'm very happy to take that forward as part of the correspondence
I think
as well.
that those are really, really significant things, and I know the distress that this particular issue caused.
No, thank you, Dan.
I think it's maybe just worth pointing out in a gentle way as well that was all discussed at the forum, and we had representatives from the hospice and we had representatives of North and South, and it gave a good opportunity to really talk that out. And there were some actions from the Interparliamentary Forum of letters being written, and it's good that we do it as well, but it just shows you the value of that North-South coming together to get the two different perspectives on the same issue, what the differences are and how we can work them forward and work for the better of people. But definitely every single one of those issues that you mentioned there, Diane, were discussed at the forum in depth.
I know, and that is really good through the chair, sorry. That is really good, but specific to what we're doing here and what we can do, I think those are massive, massive issues.
And just to remind members, we do have a briefing next week, or the 4th of June, on palliative care sector, and particularly services for children and adults.
Yeah.
Okay, members will also be aware of the Audit Office report released during the week on agency staff, particularly on the use of temporary nursing staff that was published. Just to suggest to members, if members are happy, that we write to the Minister, and particularly asking him about his plans and targets to reduce funding and dependence on agency staff, and to assess the cap, if members are happy with that. And just to let you know, I declare an interest in that as a Band 5 bank nurse as well. Members happy if we send the report to the Minister and ask him? Yeah. Thank you. Okay, one other item on that, so that's right person, right care. Members, this is an issue we haven't received an update on. If members are content, I propose that we write to the Department of Health and the Department of Justice for an update on this work and when it will be implemented. Everybody happy with that? Okay. Item number 3, draft minutes. I'm going to refer members to the draft minutes of the meeting held on the 21st of May at page 5 in your packs. Are members content to agree the minutes as drafted? Yep, thank you. Item number 4, matters arising. I have none. So we'll move on to our first briefing. That's the oral briefing from the department on the stroke action plan, and I refer members to page 20 of your main pack. And as they're coming in, we're going to welcome Mr. Ryan Wilson, Director of Secondary Care, Mr. Brian McAleer, Co-Director of Acute and Emergency Medicine, and Miss Fiona Quigg, Deputy Commissioning Lead of Strategic Planning and Performance Group. Thank you very much for coming. You're all very welcome.
Yeah.
Thank you. If you want to make some opening remarks, and then we'll have some questions.
Yes, thank you, Chair. I will lead. I'm the Director of Secondary Care in the Department of Health, with overall policy responsibility for stroke care. Thank you for the opportunity to speak to you today about the Department's stroke action plan. I'm joined by some colleagues from the Department's Strategic Planning and Performance Group. Brian McAleer on my left is the Co-Director of Acute and Emergency Medicine. Fiona is the Deputy Commissioning Lead for stroke, and Ivan on the far left is the Stroke Network Interim Clinical Lead. So as you know, the Stroke Action Plan was published in June 2022, highlighting 6 priority areas, and a written update has been provided to members of the committee in advance of today. So I want to first provide you with an update on the progress of the hyperacute stroke care and stroke workforce review, which are priorities 5 and 6 in the plan. Those are led by my side of the department and healthcare policy group. Brian will then give you an update on the other priorities 1 to 4 in the action plan, which SPPG leads on. So briefly, hyperstroke acute care priority 5. The committee will be aware of the 3-phase process that has been agreed by the Hyperacute Stroke Project Board to progress this work. Phase 1 of the process included initial modelling analysis undertaken by the University of Exeter. That's now complete. That has resulted in the identification of a preferred modelling scenario to take forward to the next modelling stage. The project board has agreed a preferred scenario which centres on the introduction of pre-hospital triage to assess a patient's eligibility for thrombectomy. Where that triage indicates that a patient may benefit from thrombectomy, the patient will bypass their local stroke unit and will be taken to the Royal Victoria Hospital for treatment. Other patients considered not eligible in that pre-hospital triage will continue to be brought to their local stroke unit. To avoid overwhelming capacity at the Royal Victoria Hospital, this scenario would be implemented on a phased basis. Phase 2 of the hyperacute process is focusing on an assessment of the sustainability of all 8 current sites. The project board has agreed that the sustainability assessment should be informed by the identification of the workforce needed to support hyperacute stroke care. That's currently being taken forward by the Stroke Workforce Review. That is priority 6, which I'll come on to shortly. The work will also be informed by additional modelling analysis on the impact of demographic projections on future stroke admissions. So as outlined in the paper that you've received, the analysis indicates an estimated growth in stroke admissions from currently 2,900 to over 4,100 by the year 2040. It is intended that the assessment of sustainability will also consider broader challenges, including the need for ROTAs to support a sustainable quality 7-day stroke service. If the project board concludes that all sites are sustainable, the process will end there, and we'll move on to developing a supporting business case for the Health Minister to consider. If not, the process will move into then a 3rd phase to look at identifying the preferred number and location of future stroke units. It's estimated that phase 3, if required, would then take an additional 12 months to complete. Just moving on to priority 6, the stroke workforce review. Phase 1 of that review is focusing on an assessment of the hyper-acute and acute workforce. That's nearing completion. Each trust has provided workforce data returns, and a validation process to bottom out that baseline is currently being undertaken by the project lead. In the context of ongoing engagement with the clinical advisory subgroup of the stroke network, there's been a number of queries to the baseline data, and that has just been part of the ongoing refinement and finalisation of that data. So that will be completed in the coming weeks to resolve any final outstanding queries within each trust, and will lead us to an agreed and established final validated baseline of the current workforce. In addition, engagement with our imaging colleagues within the department has been undertaken to understand the implications of this projected stroke increase on imaging equipment and workforce. So the project lead has completed a review of sources of guidance on the recommended workforce levels. That includes the National Clinical Guideline for Stroke and guidance from both the British and Irish Association of Stroke Physicians. That guidance is used to identify the basis for estimating the recommended workforce levels to meet total stroke demand, including stroke mimic activity. The methodology has been agreed by the Clinical Advisory Group and the Stroke Workforce Review Steering Group, which oversees that work. The next steps in that work is to complete Phase 1, includes the identification of the recommended workforce levels, to include both the current and projected activity, a gap analysis between the final baseline and the recommended levels of workforce, and an assessment of the steps required to close any gap. That work is expected to complete in the coming weeks, and the steering group will be reconvened to consider and agree a Phase 1 report at that time. In terms of funding, the funding requirements for hyperacute stroke care and the workforce review will be identified when each project is further progressed. It's likely, however, that some additional funding will be required to support implementation, and it's important, therefore, to note the wider financial context that we're operating within. And while a final budget has not been agreed at this stage by the Executive, it's anticipated that the Department may be proceeding through the current financial year with a significant funding deficit, of which you'll be aware. I just want to hand over to Brian now, who will provide an update on priorities 1 to 4.
Thanks, Ryan. As Ryan said, Brian McAleer, co-director for acute and emergency medicine within SPPG, and I've recently taken on the remit of stroke as well. So Chair, thank you. I'll give you a brief update on progress regarding priorities 1 to 4 of the stroke action plan. So that's prevention, thrombolysis, thrombectomy and rehabilitation. So firstly, with regard to TIA services, a regional model for 7-day TIA service, expanding from the current 5-day service, has been developed and shared with trusts. Trusts are working to implement that as far as possible within existing resources. However, full delivery will require investment in radiology and workforce and infrastructure. But in the meantime, high-risk TIA patients presenting at weekends are considered for admission depending on how serious they are. With regard to thrombolysis, an audit of missed thrombolysis opportunities led to a clear action plan, including the introduction of artificial intelligence in stroke imaging and continued public fast messaging. The introduction of AI in stroke imaging on all sites has led already to improved identification. So variation between some sites still remains. Alton Galvin Hospital is now participating in the NHS Elect Thrombectomy and Thrombolysis and Acute Stroke Collaborative, which has a strong track record in improving performance. In parallel, a regional sensible care project is on the way, which is focused on reducing unwarranted variation and improving consistency across Northern Ireland. Learning from both those programmes will be shared regionally. The expansion of the current thrombectomy service to a 24/7 service remains a key priority. Belfast Trust has just submitted a draft business case, which is started to review with the Public Health Agency. So investment will also be required in the ambulance service in local hospitals to ensure equity of access. And the ambulance service one is an important one because quite often services change and the impact of the ambulance service isn't taken into consideration. So that's part of that process. The total estimated recurrent cost is around £5 million. That'll be between the Trust, Belfast Trust, and the other trusts and NIAS. We're hopeful for confirmation from the Minister of the service expansion shortly, subject to business case approval, allowing the Belfast Trust to move at pace to get the service operational. And look, it's important to say, normally we don't issue a business case until we have a confirmed source of funding. We've already started that process in advance of the funding being announced, and that's to ensure that we don't add any further delay to the process. So, assuming the business case is signed off and funding is available, the service could be operational within 4 months of business case approval, meaning no patient would have to wait for this time critical treatment. Full implementation would obviously take a bit longer. You'd be chatting probably up to 12 months to allow for workforce lead-in, but the service should actually start to expand within 4 months. So 24/7 access would ensure that patients currently assessed as eligible are not delayed in receiving treatment. In the interim, steps have been taken to maximise access within the current hours, including regional protocols for out-of-hours assessment and transfer. And as a result, Northern Ireland's thrombectomy rate for 24-25 was 5.2%, which is higher than England, Scotland and Wales, so the unit is performing extremely well. In terms of rehabilitation and long-term support, a regional community stroke service model, aligned with national guidelines, has been developed and shared with trusts. Workforce gaps will be quantified through the regional workforce review, which Ryan talked about. And work is also underway on a regional spasticity model supported by education programmes. So in conclusion, while progress has been made across the pathway, the expansion of a fully resourced 24/7 thrombectomy service remains critical to improving outcomes, reducing variation and ensuring timely access to life-saving treatment for stroke patients in Northern Ireland. Thank you.
Presentation, is there anybody else to add to that? Or?
I think that's us. Over to yourself.
Just let members know, you'll have in front of you the response from the Minister of Health about the thrombectomy service. I think it's on everybody's desk, and I think it has been emailed to members as well. So, yep, thank you. And obviously refers to the business case that you were speaking about there, Brand, which I think all members will be very glad to hear this. It's been a long time coming, and I know members have been very vocal about asking questions and speaking to campaigners and the Stroke Association and stroke survivors who are very keen to see this implemented. So, it's great to see that there is progress here. Okay, we do have a few questions. Can the committee expect to receive the outcome of the business case after it has been submitted to SPPG? Is that?
I suppose once we have the funding in place and we review the business case, we can certainly notify the committee that that's been approved. But like I suppose even the conversation with Belfast Trust, we're asking to start planning that the resource will come. Now obviously they can't recruit, but they're starting to plan internally on how that'll look. And because you're expanding existing service, it's not like you're starting from scratch. But yes, certainly we can share that with you once it's signed off. Yeah.
Oh, fantastic, thank you. A couple of questions now. There was one you mentioned there just about the spasticity services across the trusts, and I know there is a drive to make this a regional service. Just ask who delivers this service? Is it predominantly medics? Is it nurses? Is it healthcare professionals in any way?
Yeah. So spasticity can be managed by physiotherapists and occupational therapists on the ground, depending on the level of need. So the model that has been developed or is in development at the moment has a number of tiers. So there are core elements of spasticity which could be managed within existing trust services. And that's what we're doing through the educational forum, is making sure that OTs and physios are aware of what they can manage and optimise within existing resources. The model then looks to a regional hub, so there's a level of complexity which can't be managed by core spasticity or core physios and OTs, and that would need a consultant input and then specialist physio input to it as well. At the moment we have a number of consultants who are trained in injecting and using guided injections, I suppose, essentially. There's probably an inequity of access because it's not available in all trusts. I think the model would like to see that hub being developed, which would ensure then that once patients are optimised within their own trust, there would be a referral pathway through to a regional spasticity model. Now, spasticity doesn't just affect stroke patients, so there is the potential that learning could translate into other physical disability services. Ivan, is there anything from a clinical perspective you want to add to that?
I don't think so. I think it's a tiered model involving a whole team, people as part of teams delivering the core service, but also having that facility to have a regional specialist support for more complex cases. But that's pretty much it. Yeah.
Just add as well, the regional community stroke model, it's based on national and NICE guidelines. So it is based on, I suppose, very, very strict standards. So it's not that we just, we should have a consistent approach. That's what we're aiming for long term.
Thank you. Can I ask what progress has been made to develop pathways for referrals for clinical psychology and mental health services for support for people with stroke?
Lead on this, Fiona?
Yes, as well. We have clinical psychologists within the stroke network, and they have also developed a tiered approach. So there are psychology services which can be delivered as part of occupational health. Then there would be the increasing need which would require clinical psychology. We do know we have a gap in our workforce, so every trust has funding for a clinical psychologist, and I think the most recent data I have is that all those posts are now filled. However, the demand is greater than one post, and the gap in that workforce will be picked up through the workforce review. So at the moment, there will be the level 1 will be managed within community teams and also within the OTs in the hospital setting. But we do recognise that there is a gap there towards the higher tiered requirement. Even if we have funding, we know that trusts over the last number of years have had vacancies and have been difficult to fill. So whilst there has been funding, they haven't been able to recruit. And so I think alongside the financial requirement, there also is a workforce education requirement to make sure there are enough people coming through with the necessary skills and experience to be able to be recruited. Ivan, is there anything you want to add on that? Perfect.
Thank you very much for that. I'm happy to open it up then. If Diane, I think you're first.
Yes, thank you, and thank you for the presentation. Can I go back to the issue of staffing and across the broad range of services for stroke in Northern Ireland? And it seems to me that in the papers you talk about a lot of reviews and a lot of work being done. Are we adequately staffed?
As I mentioned in my remarks, the first phase of a 3-phase review of workforce.
Sorry to interrupt, Ryan. See, that's what worries about me, because when I listened to your remarks, I heard a lot about reviews and of reviews. So I just really want to know, are we, at this moment in time, can we assure the public that we are adequately staffed?
And just to be clear, you're talking about the full range, pre-hospital,
Yes.
hospital. So I'll maybe just speak about the phasing of the review, and I might be able to hand over to Ivan, who can give you the first-hand experience of that. So the reason why it is obviously in 3 phases, the priority for that is our acute workforce and to establish what we currently have and the gaps. The adequacy of that I might leave to our clinical colleagues to determine. We are trying to plan for a growth in admissions and a growth in incidents up to 2040 as well. We will then look at the further phases of the review, which are the community support and discharge, early supported discharge and community rehab, phase 2, and then in phase 3 the prevention element of the workforce. So in total that will be a first comprehensive look at the full range of workforce skills that are needed to deliver this service. It is a process there's complexities within that, as you'll appreciate. There are people that aren't necessarily delivering purely stroke care. There are mixtures of jobs. So establishing the baseline of what is currently delivering stroke care is a complex exercise, and it's taken some time to work through. I might just bring in Ivan at that point to give you his first-hand on the ground view of the adequacy of the workforce.
Very good question. I suppose we can reassure the public that we partake in SNAP, which is a national audit of stroke care, which compares care with England, Wales and Northern Ireland. So we're in part of a big group of centres delivering stroke care. In the broad, our performance in many areas is better than the average in SNAP, and when you compare across England, Scotland, Wales, Northern Ireland, we're certainly adequate, if that's the word to use there. I suppose the thing I would say is that stroke care is constantly evolving. The complexity of acute stroke care has evolved massively in the last 10 years, so we have to keep thinking ahead. How do we develop our workforce to deliver this? That involves existing clinicians taking on new skills, learning new things, and also training the next cohort of people coming through. It's certainly more complex than it was 10 years ago, and that's a challenge for us going forward. I suppose at an individual level, there are patches where people struggle to recruit, where there are vacancies, where there are locums being used. So staffing has always been a challenge. But I suppose the reassuring thing is that we, despite those challenges, we work very hard to maximise the care delivered, and it certainly is comparable with standards across the SNAP cohort of trusts.
So maybe adequate wasn't a great word to use, okay? My information is that there will be an increase in stroke patients to about 4,000 per year by 2040. How can we optimise the workforce to deal with that? And what do we need to optimise the workforce to deal with that rise in stroke patients? And maybe with new technologies and innovations, we won't always need physical presence in the way that we do, but what do we need? I just tend to think that I get here from across Northern Ireland and I get a variation of reports. Some in terms of rehab are excellent. I was in the stroke ward in Craigavon, and it really is very humbling to see people who have been very, very ill have, if they are suitable for it, a thrombectomy, and the consultant there described it as like a little miracle, you know, and it's good to know that it is a good thing that we will have that available 24/7 in Northern Ireland. That's important and that's good. But there is a range of services that are needed to treat stroke. It's not just one. And how are we going to, I mean, will we see the results of the process that you're currently carrying out? And will we know exactly how many people we need in each area from that analysis? I really don't want it to be like the palliative care scoping exercise, which seems to be going nowhere fast.
So,
you know, I do. This is really important stuff.
And I can assure you on that, and this is a distinct workforce review, as you said, covering a broad range of different skills and specialties. So different than the exercise you're referring to, I think. Yes, to assure the committee, you will see the outcome of the workforce review, and that is its aim is to ensure that we are planning for the workforce we need today across the full spectrum of care and
that
into the
increase
future.
in patients that we will have.
Yeah. And that will inform the work alongside that I mentioned, which is to determine how we establish and move into hyperacute stroke care. So that those are interrelated. You've also mentioned that rightly the possibility that technologies developments might change the way that we model the workforce. So this is we have to work with our best estimates at modelling, and those will be taken into account as we progress. But to your question about sharing that with the committee as we work through the phases, absolutely, that could be made available.
I think that is important, because I think we saw in the news this week the impact of not having proper workforce planning in terms of agency staff and so on. So it is important that we have proper workforce planning that benefits patients and patient outcomes, but also is appropriate and good value for the money that we spend. There's just two more questions. In relation to, in 2019 you consulted on reshaping stroke care, and there was to be decisions on the hyperacute units. Can you bring us up to date on that, and what has happened or not happened, and the impact that has had on stroke patients?
The process we're in at the minute is in effect a revised approach to that to determine what the hyperacute need is and the best configuration for that. The process undertaken in 2019, now I wasn't directly involved with that, but aware of the public consultation and a number of options that were consulted on at the time. That has in effect informed the position of where we are now. I think what we're now doing is in using better, more enhanced information on demographics and future prevalence, future trends to inform that process. So
really, what are you saying to me, that nothing happened after the consultation in 2019 and you're now revising and remodelling?
Well, there wasn't any reconfiguration of the service following that. So
nothing happened in 2019?
I'll come in on that. Just so we're clear about it. So
because I think the problem, Fiona, is that we seem to spend an awful lot of time consulting. Like 2019, we're in 2026. That's 7 years ago.
That decision sat.
That is quite a shocking amount of time in which we haven't taken a decision.
Yes. The consultation closed in 2019 and there was a ministerial decision due in August 2020. And we know in March 2020 COVID hit. So that impacted the decision. And Robin Swan issued a paper in 2022 alongside issuing the stroke action plan that they needed to go back and revise the process because it didn't reflect it uplifted the Northern Ireland population at a regional level as opposed to looking at local need and demographics. So that decision was probably shared with the committee at that point in time, and then the decision to go back and restart the process, taking into account demographics at a small geography, and that's the modelling that's gone on to date. And I suppose that's a three-phase approach. So phase one was looking at what's the optimal configuration. So where can patients basically get the best outcomes using the existing hospitals? Then the second, that has been complete, and that's what Ryan updated on, that patients with the potential who are potentially likely to need a thrombectomy are taken into the Royal, and all other patients go to their local unit. Now the process is looking at how sustainable are 8 sites, and once that piece of work is complete, possibly towards the end of this year, a decision will be taken then, do we need to reconfigure? So appreciate the delays. COVID did have an impact, and that delayed Robin Swan's announcement in June 2022. He issued a paper on the outcome of that consultation exercise with the recommendation that the process needed to be revised based on the consultation outcomes.
And I don't doubt that COVID had an impact. I'm not saying it hadn't, but it's not an excuse for everything. And it's quite some time ago now. And 7 years is a very long time, and we're still in process. And it seems to me that one of the things that frustrates me, I'm not probably just ranting because, but anyway, one of the things that actually frustrates me is that the department's really good at throwing stuff into process as opposed to making decisions and outcomes for patients. And this is an example of it, where we've had 7 years of process. Anyway.
If you don't mind, I would maybe just come back to answer that point. Since I've come in as policy leader, the policy has moved to me in the last 6 months or so. What I've seen is a network of this team, wider stakeholders, really dedicated and have been working throughout that entire period, through COVID, through the suspension of the Assembly, to progress this work, to establish the evidence base for a future model of care that will meet the needs of this population. There has undoubtedly been barriers, pauses along the way, and limitations due to capacity within the teams and due to the lack of funding to take forward service developments over that period. But what I have seen has not been the lack of effort and collaboration across all of our system and all of our trusts, and led by Fiona and Ivan and others, I should say, to take us to the point. I think the process, we acknowledge, has been a long time since consultation. There hasn't been a reconfiguration decision taken from that point, but we're in a process now which I'm confident is on track to deliver along the timelines that we've outlined. So we are where we are effectively with it.
Well, yeah, we are where we are. I mean, this is not a personal issue. Please, it's not. Can you guess how many times we sit here and hear about things being in process? Like a lot, an awful lot. And it is very, very frustrating, and particularly in 2019, and particularly since stroke isn't something that you can put off. It's an immediate, it has to be dealt with, and there are consequences of not supplying appropriate aftercare as well, which in some parts is better than others.
And maybe if I could just make one comment, I think those are very relevant points. I just maybe refer you to the written update that the committee received across the 6 priority actions. Within the available capacity and budget that we have available, there has been as much progress made as is possible given all those constraints. I'll not go over them all in detail, but we can pick up on any of those if the committee wishes to. It is a case of demonstrating or attempting to push forward service improvements with admittedly limited capacity and investment. And I think we're trying to build on that. The decision that you referred to not being taken is on the configuration of hyperacute units. It's not to say that progress hasn't been made across the other priorities.
Thank you, Chair.
Thank you, Diane. Nuala?
Thank
Sorry,
you.
maybe bring Ivan in there at that point.
Apologies. From the clinical perspective, I was involved in the previous process, and I suppose as a clinician in there, my primary aim is that people who get a stroke get the best chance of recovery, and that pathways and processes don't get in the way. And that's the whole idea of reconfiguration. Is obviously you want to get thrombolysis as quickly as possible, but you don't want that to delay thrombectomy. So there's a bit of a trade-off, and that's where the whole idea of reconfiguration comes in. And obviously the consultation raised very serious objections from the public, particularly in regard to demographics, which have been taken account of. From the clinical perspective, sort of keeping in mind why are we doing this, we have worked very hard as a network to actually optimise our thrombectomy rates within the existing service. We do have regular meetings with all the clinicians involved, demonstrating cases, updating on pathways, updating on imaging. There's a lot of work goes on behind the scenes to try and make sure we get the right referrals coming through and to ease that process, and that has really improved over the last 4 or 5 years. So there's quite a lot has happened on that end. Also on thrombolysis, as was mentioned, Altna Gelvin is now taking part in a national programme to optimise their thrombolysis rates. We're trying to roll out some of those ideas across all the other centres as well. So there's a lot happening to achieve the key goals of reconfiguration, even though reconfiguration hasn't happened. So, and if it needs to happen, which is obviously what the process will tell us. But there's a lot happening to try and deliver hyperacute care.
And please do not imagine for 1 second that I believe that there isn't a lot happening. I have been over in my local hospital in the stroke wards talking to consultants, talking to physiotherapists, and it's an amazing job, and with some very sick people. It really is.
Do you mind if I come back to your point just on the workforce and the community piece of it? Because like, realistically, our community demand is the same irrespective of our hospital demand. Those people will still be coming back to those local areas. The guidelines significantly shifted the barrier or the marker in terms of what therapy people should benefit or should receive. So that really our workforce would be very stretched to deliver that. They were stretched on the previous guidelines, significantly more stretched on the new guidelines. So, we are working within the network to see about group sessions. So rehabbing people as part of a group. So 2 staff can maybe deliver to 5 or 6 people at the one time. And also the use of virtual reality technology. So those types of things will make a difference in terms of improving the amount of rehab we can deliver within the existing workforce that we have, but the changed guidelines did impact on what's required of them.
Brian, so you wanted to comment there?
Yes, I suppose one of the good things we have is the fact we're involved in SNAP, so that's the benchmark that tells us how we're doing against all the units. And this was having this conversation with Fiona earlier. It was like my GCSE result, or whatever result actually. So prior to September 24, when they changed the guidelines, our units, we had one which was sitting at an A, 3 at Bs, 2 at Cs, and 2 Ds. The guidance was then changed. Basically, they recalibrated SNAP, and they basically looking for further improvements. We're not doing as well now. We're 1 at B, 4 at Ds, 2 at Es, but that then drives the conversation with the trust on each specific one. Where are you falling short against the guidelines? And then there's local action plans with each trust to say, right, how do we get you to improve? But I think it's important to say that prior to the change in the calibration, they were all performing really well. And now the next job is to get them all up to that standard. So while the conversation about the reconfiguration, and I can't argue with your point on how long it takes, we're not sitting still. We're keeping trying to improve, and we talked about the AA and those other things, and that's where we keep driving. And the SNAP data is key in that there. That gives us a benchmark, which we don't have in lots of other areas. And this is one that even with some of the challenges with EPIC, we're still able to keep feeding the SNAP audit. So that's an important point.
Thank you, Brian.
Thank you very much. I am the chair of the all-party group on stroke, and we have had, you yourself have been to a number of events and the APG, and we've had an opportunity to engage with clinicians and also service users and their families. So we've seen it from people who've been able to get a thrombectomy, those who have not. Even I think the youngest was a 20-year-old that we met here in Stormont, which can be shocking to quite some, because people mostly associate a stroke with older population, but it's not just anymore, or never was. One of the issues that arises is about support, and Fiona, you had talked about the neuropsychology and said how there was now a consultant in each of the trusts, but back at the last time we discussed this at the APG, I believe it was just in one trust area at the time, quite possibly, has a psychologist just, that specialises in the services provided for by stroke. So is it all trusts?
All trusts have funding for it. At that point in time, there was only one trust had anybody permanently in post. As far as I'm aware, they have all filled their vacancies.
Okay.
They had to look for innovative ways, so some brought in through a preceptorship route, with a 1 year and then the next year they would be promoted on to a clinical psychology post. So it's Evan, you can correct me on this. It's a clinical psychologist, so whether is that I don't think they're necessarily a consultant, are they?
Necessarily consultants,
but they have a dedicated clinical psychologist. So I think it was actually a relief to get that, and I can come back and confirm. But as far as I'm aware, they've all filled their vacancies. Yeah,
well, that would be good movement from June, from January, the last 6 months, because I believe the Stroke Association and the STEPS programme, they had 1,000 referrals, and since in their existence of counselling. But one thing that they also had said was that there was a bit of a gap in referrals from clinicians to counselling provision and services, and is that something that is also examined currently, as part of either the Stroke Action Plan or in terms of that holistic support, that it's not just rehab, but it's
long-term
also
support piece, yes. And we have a long-term support specification that's setting out what people should be expecting beyond their statutory provision. And even the Stroke Association, their STEPS programme could happen alongside statutory rehab. So certainly if there were any gaps identified, we'd like to know that we could raise that with the trust.
And is it automatic? Does a person receive? Is it automatic, or does a person have to request, or is it advised? So how does this happen?
They can self-refer, or they can be referred through the community stroke service. Or if they're on a ward, the rehab team within the ward could refer. But generally, the line would be from community stroke through to the community and voluntary sector, their STEPS programme.
So yeah, that was just one of the issues that arose for us then, was that it wasn't statutory referrals, or even there wasn't no uptake then, because it was just one post. Yes. And that's something perhaps that we could have a little bit of feedback on, about how that service is better? Is it offered more? Because one thing that did arise was about that kind of mental health support as well.
Whenever COVID hit, we had our two charities, Northern Ireland Chest, Heart and Stroke and the Stroke Association, and trusts were able to refer into both, and they came together. So there is one pathway. So the trust refer into one pathway, and I think it sits with the Northern Ireland Chest, Heart and Stroke, and then they triage and they will onward refer. So it'll be worth, I can raise that with trusts to make sure that any referrals that they make through that pathway are being picked up and appropriately signposted. But if there's a gap in people actually being referred, well, then that's something that we need to raise with the trusts.
Okay, thank you. That'd be helpful. And another thing that we spoke about that has been mentioned at the last APG was the pit stop pilot. I know I had tabled a question, but it's not been answered yet around just kind of evaluation of it. Has that taken place, or the assessment of the trial? I don't know if it has had enough time, but can you elaborate a little bit more on it?
I certainly can. I'll need to go back to Elton Galvin and ask them for a specific evaluation on the pit stop trial. However, I think we're going to put a bit of investment into the NIAS as part of the thrombectomy business case. And those early discussions, I have kind of alluded to them. We would like, if trusts are able to scan people within a defined period of time, which we will be able to measure on SNAP, that they would implement pit stop across all sites, because obviously that's reducing the time to the Royal. It's also making more efficient use of one ambulance rather than any potential delays on in a second. But I will go back to
Is that still only in operation at Altmagelvin then?
Yeah.
So we still have people who have a stroke go to their local A&E, and then they have to wait in a further ambulance then to go to the Royal?
It can depend on the clinician there on the day, who may well run outside and just say to the ambulance, wait. Yeah. Officially it's Altnagelvin, but in practice it could be other sites. Certainly Southern Trust have been in communication with NIAS about rolling it out through from Craigavon. But I think we would like to see it mainstreamed as part of the business case.
And given how stretched that the ambulance service is, do we think that this can work in parallel as to when 24/7 could also be coming in effect? Because if we didn't, then what's the point?
I mentioned on the £5 million, the sum of that will go to NIAS to put additional capacity in. And look, certainly when we're having the conversation with NIAS as part of that, we can have that talk about the pit stop and can we get that built in as part of the additional money, so we can, in a sense, make that conditional on the funding.
It would absolutely have to be, because if we're going to reconfigure services, no matter where in healthcare, it shouldn't impact you if you're rural or urban. You should all have the same kind of treatment. And this business case then, just going back to it, we had the letter and the business case, an estimated 5 million per year, and it would take 4 months once granted. But where are we before the beginning of the 4 months? Are we talking this financial year, this calendar year?
Or this calendar year.
This calendar year that we could start rolling out 24?
And look, I suppose it's important to say, we haven't waited. The normal process is when you have a funding source, you issue the business case. The business case was issued several months ago. The conversations with the trust were happening a month before that to start planning for it. So we're ahead of our normal process. And look, you can be assured that we will be doing our best to expedite this. Now, obviously, there's the proper checks and balances to make sure you're getting value for money. But the trust are actively planning to expand the service, and I don't know whether you want to see even some of the clinicians and their view and the goodwill, I suppose, that you get when they know this is coming.
Yeah, there's huge appetite to get this going. One of the big issues for clinicians involved, when you're not able to treat someone, the moral injury with that, and that's a cumulative thing. That happened during COVID, and then everything moved on, but this is something that keeps happening. So we're really keen for this to happen. There's a lot of goodwill and a lot of push to get this over the line. The last thing we want to do is not be able to treat somebody when they present, and I totally agree that once the lights are on 24/7, we need to get people there quickly from wherever they are. And just come back to pit stop, I suppose the evaluation will look at people who didn't get transferred and how long those ambulances had to wait and what the impact was on their time, and that's the challenge. As someone, I'm wearing my clinician hat here, at the other end of it, receiving people, we've had cases have come from Altnagelvin very quickly, and I'm pretty certain their outcome was much better than if they'd waited over 2 hours for a door in, door out time, which would be the standard. And that's not just a Northern Ireland problem, that's across all of SNAP.
Okay.
So we would be absolutely behind getting people to us quickly. I think we probably can be a bit innovative about pit stop, that we don't have ambulance waiting on everybody. If somebody's clearly not eligible for thrombectomy, potentially that patient could be stood down for pit stop very quickly. But if someone looks like a large vessel occlusion who would be transferred, then we potentially could have a focused approach. And I think those conversations need to happen. But on both counts, getting 24/7 and getting pit stop operational, clinicians would be totally behind that.
Okay. And then also the question and the use of AI, if you could, just from a clinician's point of view, outline the benefits as to how you've been using the imaging and how that might actually speed up or help assist consultants, clinicians and a patient who's in a different site. If you could just explain that first for a person who's not a doctor, hasn't gone through years of medical training, but actually how the use of this new technology helps you to carry out your work.
So we have a standard imaging protocol that works across all sites. We have the same AI package. So anybody who gets a stroke protocol CT scan, that will come through to our mobile phones instantly. So we do a package of scans. We do a plain CT scan, which just shows the brain. We do a CT angiogram, which shows the vessels, which is essential to see if there's a large vessel occlusion. And we quite often do a thing called the CT perfusion, which looks at the perfusion of tissue and shows tissue that can be salvaged, basically, to keep it simple. If someone phones me from Craigavon and says, I've got a 60-year-old with an acute stroke, usually before they phone me, the images are on my phone. If I've looked at them, if it's clear cut, I can check one or two things and say, call an ambulance. I don't have to go and try and find a workstation, log in, have a look at the scans, maybe call a radiologist to look at the scans. It's all there. So for a proportion of patients, it makes it really easy. It doesn't remove the need for human interpretation.
Of course, yeah.
There are other scans that are really tricky.
Does the AI actually interpret it too?
The AI gives it gives you a picture. Probably could show you it, but it gives you a picture. If there's an obvious large vessel occlusion, you'll see the scan like the branches of a tree. There's a big branch missing. Just in case you don't see it, it usually draws a red ring around it. There's a colour map of the brain if the area is not perfused. The brain that's salvageable is green. The brain that's gone looks pink. So if you've got a small pink bit and a big green bit, you know if I can get that vessel open quickly, I can salvage that brain tissue. So it's very, very easy to use.
It's an excellent innovation using AI
for the patients that are straightforward,
yeah.
it totally shaves 10-15 minutes of the process time.
Okay. And every minute and stroke every second really counts. Look, thank you very much. This is very positive news, I think, for stroke care to hopefully get the 24/7 rolled out as soon as possible. It's most welcome, and a lot of people who've been championing it, and a lot of organisations will be happy once it hits the ground. But thank you very much.
Back on the business case, and I suppose the queries that are going back and forth between SPPG and the PHA and the Trust at the moment, like, we have known for some time, we've had a costed model, we know what workforce you would need to deliver 24/7 thrombectomy, but given 300 patients over a year, there's not every night that people are going to be called. So what we're trying to do is say, well, what else can those people be doing? So it's trying to drive the value for money piece as part of that investment, and that's really where it will not only thrombectomy is cost effective, but this business case, this expansion.
You expect those people actually, that's just triggers, and you expect those people then to be on site 24/7, yeah?
No, some of them will be on call. Yeah. So if they're not called in at night, then they would be expected to be in work the next day. So then what can they do?
Yes.
Because they're on call, there's maybe they will not be rostered maybe for the next day.
Yes,
so
yeah.
It is really about maximising that.
Just another point in that, it's not about just putting more consultants into Belfast. Some consultants from other sites will also be involved in the rota. So you don't have to say put, but like the way Primary PCA works, you consultants from other trusts that provide the service. So you're actually, again, it's value for money. You're maximising the resource that you have.
Okay, thank you.
Thank you, Brad. Alan?
Thank you, Chair. Just to have some discussion around the discharge planning arrangements within Priority 4. I'm aware of ESD model of care, early supported discharge.
Yeah.
And I'm just keen to learn a wee bit more about that. My limited understanding is that it allows for therapy that otherwise would be provided within hospital to be provided at home. Things like speech and language therapy, physio, OT, 5 days per week, 45 minutes of care. Is that correct? And could you maybe expand a little to allow the community to understand this a little better?
Yes, so early supported discharge is now part of our community stroke model that we have developed for Northern Ireland. We previously would have looked at it as kind of a separate service from the community stroke team, but they're all integrated into one. So yes, you are right. Where a person does not need to be in hospital, they're essentially medically optimised, they can be discharged through to the community stroke early supported service. So they should be seen within 24 hours of discharge, and they should continue their therapy at the level that they would receive in the hospital. So that's effectively improving your bed flow, and early supported discharge is one of those interventions that has a good evidence base in terms of improved patient outcomes. It is difficult to deliver in terms of the demand and the capacity with the workforce, but it has its evidence base there. And through transformation funding over the last number of years, we have invested within the Southern and the Western Trust and their early supported discharge teams. So the only trust who does not have early supported discharge is the Northern Trust. Okay. But what we've done is asked them through their triage process is to identify those patients who would most benefit from therapy and prioritise those. In terms of the 45 minutes, I think that has kind of now changed to up to 3 hours therapy over 5 days in a week. No, we know that we can't deliver care at the weekends. We're not funded, or we don't have funded trusts to deliver at Saturdays and Sundays. Some trusts do have rehab assistants who can go out at the weekends, but the workforce that would be required to deliver that on a 7-day basis will be picked up through the workforce review.
So, someone who represents the Northern Trust, are you saying that the Northern Trust have a lesser service than those other trusts, the Southern and Western?
They haven't specific funding for early supported discharge, so they would not have the same level of capacity to respond.
How do we fix that? Because I think it's very important that we fix. I think this is a proven model of care.
Yes.
We understand that there's been clinical trials in England and in the South, which has proven that this is very effective.
Yeah.
So I think it's something very important here that we pick up on.
And it is a financial gap. That's the reason.
Financial?
Yep, purely financial. The Northern Trust have been offered funding at the same time the Western and the Southern Trust, but declined because of the non-recurrent nature of the funding.
They declined it?
They declined it, yeah. We do know it's one of our priorities. After thrombectomy, I think early supported discharge would be the next priority, and spasticity. So it's high up in the priority list to get that implemented. But again, we don't have funding to increase our staffing levels, and the staffing levels that would be required based on the new guidance, that will be picked up through the workforce review.
How long has ESD model of care been available in those other trusts?
Southern and Western Trust transformation funding probably 2019. Ivan, you're here much longer than I am. When would it started in Belfast?
Yeah, we were involved in one of the early trials back 20 years ago. So it's been a philosophy in Belfast to try and develop that. And I suppose in terms of the amount of rehab that goes in, I know we used to talk about 45 minutes, we're now talking a bit longer because of the new guidelines. In the early trials, it was nothing like that amount of rehab that went in, but it still showed that compared to getting rehabbed in hospital, the outcomes were better, that death and dependency was significantly reduced by about 20%. So it is a model of care that we definitely would wish to expand. And I suppose there's a wee bit of convincing patients and families that actually getting out of hospital is better. That they will actually do better if we can get them home and get the rehab they need at home. So absolutely, it's got an evidence base which was based on much less rehab than we're trying to give now, but it's even with less amounts of input compared to hospital input, it is better.
We can only persuade them out of hospital if that model of care is available out of hospital. And
Well,
the
it needs to
Northern
be
Trust,
there.
it's not.
Yeah.
It needs to be there.
Okay.
That's something I think we need. Just one other then question, just beyond the FAST campaign, do you feel that public awareness of the importance of acting fast for those who have suspected stroke, do you feel that that FAST campaign has been effective, and do you feel that there are any other measures you think that you should try to target?
I'm going to turn to colleagues if they can take this, or if it's one we might need to come back. Can you speak to that? Or
Yes, I think we encourage the promotion of the FAST campaign, and it's run through social media, etc. at the moment. It certainly was one of them, and when campaigns were being monitored, it was one of the most effective campaigns in terms of people recognising the signs and symptoms of stroke. Yeah. Do you want to
Just
pick up on
add,
that?
it's incredibly important. When we look at the reasons why people don't get thrombolysis, by far the biggest reason is they present too late. By far. You look at all the other reasons, and there's 2 or 3 every quarter. People presenting late is by far the biggest reason. Now, we are using AI to treat people who present late, people who wake up with a stroke who don't know the onset time. We can use AI to say this brain's actually salvageable. We can go ahead with lysis. So we have made inroads into late presenters, but it's definitely in the patient's best interest not to delay, and that's a really important thing not to forget.
Even does that suggest then that the FAST campaign has not worked as effectively?
No, I think the evidence is it has been effective, but I think we need to keep focusing on that and revisiting it.
Keep driving it home.
Yep, absolutely.
Thank you, Chair. Thank you.
Thank you, Alan. Colin?
Oh, thank you, Chair. Yeah, just I remember a summer's night in the late 2010s going to one of the consultation events about this reconfiguration, and one of the things that has sat with me from that was the fact that the consultation document itself actually suggested that if things were implemented, that round about 2 lives per month would be saved, kind of equating that out to about sort of 20-25 lives per year, and we're 7 years down the line. That's 140 to 175 people that have died because we haven't implemented what has actually been implemented here. Can you give me an assessment? Is it any stage in that it been a political decision that has caused that prevention, or is it entirely been because of medical reasons that we're taking additional time to implement this? Because I know that there was a full programme of consultations, and then that was suddenly paused, and then there was an entire reconfiguration of the reconfiguration, as has been referenced. Was that a political decision based on medical evidence, or was that a political decision based on just political decisions amongst other things?
I think I've understood that, but can you just maybe clarify the political decision you're talking about? Are you talking about the absence of a decision?
So there was a consultation which had recommendations, then that was paused and we went right back to the start again, and then that's led us to where we are today. So essentially, if we had implemented the original consultation outcomes, which it was suggesting would have saved sort of 20 to 25 lives a year, what I'm sort of saying is, was that decision to go right back to the start of the consultation again based on medical grounds, or was that based on a political decision that was taken?
So I'll maybe just start here and bring Ivan in if I can. What was consulted on in 2019 was a number of options, a number of configurations that could deliver hyperacute stroke care, which would lead to those improvements and lives saved. So there wasn't a decision or a preferred outcome to that process. We've talked about COVID impact, etc. So there was not actually a decision taken, and I would describe it as an evolution or a following through of that process, which has led to now a revised and probably a better evidence base for the process that we're currently in. So there hasn't been, I think, now again, just forgive me, but I wasn't directly involved, but I know that advice was given to the then minister that led to the action plan being developed in 2019, informed, I'm sure Ivan will confirm this, by medical advice and by emerging evidence at the time about how we best go about this, and what the demographic data is that we need to bring into this process. So that I think if you're asking whether that was a political or a clinical decision. I think it was a process that has brought us to a refined and a revised process to establish what a hyperacute care model best looks like, and what a sustainable configuration will be. So we're still in that. Maybe ask Ivan just if he can add to that, if possible, around the decisioning.
I think that's basically it. I suppose you can't really underestimate the strength of the feedback and the consultation from, there's a lot of people very concerned about the proposals, and obviously everyone involved had to take note of that, and one of the big objections was that future demographics hadn't been taken into account in the process. I think, just come back to COVID, I think my memories are that we did expect a decision to be made on a model, and then COVID happened and all of that got swept aside for 2 years, and I suppose it was revisited. My understanding is it was revisited and was felt to be wise to relook at it and take into account some of the objections that had been raised by the consultation, because the purpose was actually to listen to the public, and that's what was done. And I think it's as you've described, it's been an evolution since then.
2 points in that. Number one, and it's more conversational. So sometimes we have to skip the evolutional perspective, because otherwise we'll do nothing, because everything changes in medicine. I'd say medicine now is different from where it was 5 years ago, from where it was 10 years ago, from where it was 20 years ago. And if you undertake a process that's going to take 18 months or 2 years to complete, by the time you get to the end of it, there'll be a change that there was at the start of it. So I think it's really important that we maybe ensure that we build into all future processes that there's the ability to flex that up. I know none of you were, but I suppose this could end up being a rhetorical question then, but how did those that were undertaking the consultation miss future demographics as a key issue from it, and it took members of the public that were actually involved in the consultation to point that out? Given that we're going to end up with an ageing population and people are getting older, and we know that there's going to be more older people in the future, how was that missed whenever it was looking at reconfiguration of stroke services? That would have, again, notwithstanding the references earlier to the odd 20 or 25-year-old that will have a stroke, but the majority of people that have strokes, I would suspect, are over 60 or over 70. So how was that missed?
I think I'll bring out others in here, but Fiona's mentioned before that a more refined version. It's not that it was excluded or missed from that process, but it was a population level assessment of growth. What we're looking at now, I think, Fiona's a more local level projection and modelling, which provides a more accurate basis on which to determine the appropriate configuration.
But it took a public consultation for the public to point that out, but the authors and those that are developing the policy didn't take that into consideration. It seems a bit of a...
Well, I think in fairness, I have been involved in the previous process. The amount of expertise that was brought in with that process was huge. There was modelling from the University of Exeter and also modelling from the University of Calgary in Canada, which has been, and their modelling has been used in the States and all over the world basically. So highly respected people were brought in to model. Like if you read the consultation, there clearly were some members of the public who were very concerned about their local unit may not be there, and there are quotations from members of the public that people didn't quite see the value of getting better treatment if they had to travel further. And I suppose that's the debate with this. I come back to what I said earlier. As a clinician, I think if someone has a stroke, we have a duty to try and have a model that gives them the best chance of recovery, and that means going to a unit that will have thrombolysis rates that are at least as good, if not better, than average. We want to be benchmark units, I guess, is what we're aiming for. We want to, and the big issue with thrombolysis, it's not a yes/no. There's some people clearly are eligible for thrombolysis, some people clearly aren't. There's a group in the middle that are less than ideal candidates, and it takes experienced clinicians to make the right decision for those people. And that makes a difference between having a low thrombolysis rate and having a high thrombolysis rate. The evidence from SNAP is that people who are treated for milder strokes or less than ideal candidates can still benefit very significantly from intervention. So it's about trying to do the right thing for people, and I don't know if that message got across. Demographics was highlighted, that individual areas might have different ageing populations, and that was highlighted as an issue. There was a huge strength of feeling. I've read the report, and the strength of that, I don't think I can underestimate. But it wasn't just about demographics, but I think that was one of the key things that was highlighted. And I think, in fairness to the Minister at the time, that was taken into account to respect what the public had said and move it forward.
And if I may just add to that, while I wasn't directly involved, there were a number of things, if you remember, early 2020 that were in preparation for an incoming administration and minister at the time, and the outcome of the stroke consultation was one of them. I would assure you that the process was a listening exercise on a number of options, and the department was listening to what the public was saying, as Ivan has described. I do think, this is hypothetical, but had we not been straight into COVID response for over 2 years, we might have had a more condensed version of this process that we're in, and we would have, I think, brought in that expertise sooner and gone back to respond to what the concerns that the public were outlining at the time. It's just unfortunate that it has, for some reasons beyond our control, been stretched out over a longer period. But it was, and as consultation should be, an engagement and a listening exercise with the public to take on board those views and to bring in other expertise. So that's where we are.
Well, I know, I get that, and I just feel somehow, and this is without any fact, I just feel like it's a process that just hasn't been done the best from start to finish. And the start was probably 2015 or 2016. It's been nearly a decade to get here. But I do know that you will examine it to try and work out what's the learning that we can take here for future consultations, that we don't get any of those errors. So I know that's something that you'll take forward, but we hopefully are moving a bit quicker now.
I can see how that may appear, definitely, but again, I go back to last 6 months of my involvement with this. I've seen real effort and comprehensive attempt to look at all and establish a real clear evidence base. So when we do have an outcome of that process, I can say with some confidence it will have been based on a very comprehensive set of processes and evidence gathering. So difficult as it is, and there will be complexity within that. And that's part of the reason why it does take a bit of time, even though we have momentum at this stage.
Well, it's in your hands, Ram. I know it's in good hands, so we'll see it move a bit quicker from that. But thank you all for your things there. Yeah.
Okay, folks, that's all our questions. So thank you very much for your presentation. It's been very enlightening. So thank you.
Thank you.
Thank you.
Entirely up to you. That's what I think we agreed to.
Okay, folks, just following that presentation, we've got a couple of follow-up actions. We're going to follow up on the provision of clinical psychologists and mental health support. We're going to follow up on the Alton Galvin pilot programme, the pit stop, and the quicker transfer to the Royal Hospital. And we're going to write to the Northern Trust about early supported discharge funding being declined. Why was it not recurring? And to follow up on that, can I just remember, members, we have 5 here at the minute, just if anybody is going to get up. We need to keep quorum. So, Linda, I see your hands up there. Do you want to come in?
Yeah, it was just a quick thing on the psychological support. Can you check in that follow-up if there are particular trusts that are lagging behind others?
In what way?
So they talked about the gaps in the inability to recruit in terms of psychological services, and I would like to know, are there particular trust areas that are having a greater challenge than others? Because I suspect that is the case.
Okay.
And I would just like to, if we can get a breakdown of where the gaps are in each, what the gap is in each trust.
Okay, we'll include that. Thank you, Linda.
Thank you.
Hey folks, are we okay to move on to our next briefing? Our next oral briefing is from the Royal College of Emergency Medicine. I refer members to page 20 of your main pack, and I'm going to welcome from the Royal College Dr. Michael Perry, the Vice President for Northern Ireland, and Dr. Sarah Jane McGurk, the Northern Ireland Board Vice Chair. You're not leaving us, Alan?
Sure, that
Very specific.
Good afternoon, Michael, and good afternoon, Sarah. Thanks very much for coming along today. Are you okay to give some opening remarks?
Yes.
And then we'll take some questions.
No problem. So, by coincidence of our appearance here today, actually yesterday was International Emergency Medicine Day, and internationally one of the campaign highlights was to talk about the importance of well-prepared emergency care systems, the dedication of the staff and the professionals, and crucially the risks created by unsafe working conditions. And I thought it was just to open to sit rep kind of where we are in relation to that in Northern Ireland as of our own figures from the Emergency Care SPPG dashboard on Tuesday. So on Tuesday morning we had 326 patients in our EDs who were waiting in a hospital bed. We had 327 patients who had been in our departments over 12 hours. As you may have heard of the national 4-hour target, where 95% of patients are to be assessed, treated, discharged or admitted, is 95%. Our performance for the week across the region between the 8th and 14th of May was 36%. And crucially, to our arguments is that the number of patients in our hospitals who are medically cleared to leave but have complex discharge needs was 550 on Tuesday. So patients are waiting long hours for admission. Many are in our EDs over 12 hours. We're not seeing them anywhere near the standard we're supposed to, and we have a large number of people trapped at the back door unable to leave. This is where it is today. We've been lucky, we've had great weather this week. It's May, this is the spring, summertime, this isn't winter. The seasonal viruses are not in circulation at the minute. We're still in this perpetual cycle of crisis and dire straits. So we produced our State of Emergency Medicine report, which highlighted the consequences of overcrowding and their predicted excess mortality, which hopefully you've all seen. It. One of the reasons we're here, and we estimated that there were over 1,000 deaths in 2025, with people waiting 12 hours or more for admission. And that is significantly higher per proportion of the population compared to the figures for Scotland, Wales and England. We also published by our trainees in Emergency Medicine Research Network in December was the On Cork study, which looked at corridor care, which is effectively people who are being treated in corridors, escalation spaces, floor spaces, non-commissioned beds. In the UK national average, 1 in 5 patients receive care in a corridor. In Northern Ireland, it's 1 in 3. So we are the outlier. In terms of how long our patients wait for a bed once they're deemed for admission, the median figure in the UK is average 16 hours. In Northern Ireland, it's 20. Again, we're the outlier in this. So one of the key things that we've been kind of keen to go across, because I am aware that, I'm sure the public and I'm sure many of the, the national news, fatigue, emergency departments in crisis is perpetual. I don't want us to fall into the trap of thinking this is the same everywhere. We are in a worse situation than the rest of the devolved nations in the rest of the UK. A big policy change, as you well know, was the release to rescue in April. We are due to publish today. We did survey our clinical directors, clinical leads of departments across the 9 Type 1 EDs about their thoughts on that, and we're happy to share them at the committee today. But some of the things that we picked up, we did have concerns about release to rescue when it was first published because we felt it made overcrowding worse, and over half of our clinical leads have said that they have felt that although the handover times have improved for ambulances, overcrowding has worsened within the departments. and that they feel that we're still focusing very much on the front door solutions rather than actually tackling flow through the system and exit block. So we will publish hopefully that later on today in full. That's their nutshell is where emergency medicine is today in Northern Ireland. So it's not about individual hospitals or staff, it's about a system-wide failure that requires a system-wide solution. So one of the things we've asked for is multiple party engagement with this. It's great that we're here today, and we're really grateful for the opportunity to come and talk to you today, and we invite any questions you want to ask us.
Thank you very much. And the word shocking isn't strong enough. It is a really, really concerning and worrying report. Some of the things that jumped out at me, the 4-hour target, 33.4%, and I know you'd quoted the most recent one, but that's the worst since records began. Yeah. The 12-hour target, 23.5% against a target that is supposed to be 0.
Yes.
I think 24 hours, people went 24 hours is 8.3%. Bed occupancy in ED, occupancy in ED is 137%. So for every 100 patients that get a bed in ED or a trolley or a clinical space, there's 37 that don't get an appropriate space.
Yeah.
You know, these are incredibly shocking numbers. And then the excess deaths, which we have talked about, and it's certainly something I've raised repeatedly with the Minister in the Chamber, and we talked about here, 6,323 excess deaths in the last 10 years. Yes. And the last 3 years, over 1,000 excess deaths because of those overlong waits in ED. This is unbelievably shocking, and I know that was noted as a conservative estimate as well. Morale at an all-time low. You know, these are flashing red alarm bells that are really should be screaming at us that it is a systemic issue and it does require a systemic change. Thank you again for your recommendations. The report is incredibly shocking. The recommendations there are things that can be done to help to turn this around, and the one that jumps out at me is to restore patient flow by focusing on reduced delayed discharges and improving social care arrangements, supported by an all-party executive-led approach. And I know you've quoted the figures from Tuesday there, 550 medically fit patients. Mm-hmm. And certainly I've seen this time and time again, that there are a lot of medically fit patients in beds in wards that then prevent that flow from coming from ED for patients who need to be stuck there. And I note in one of the trusts, I think a patient was in ED 5 days. Mm-hmm. You know,
that wouldn't be uncommon.
It wouldn't be uncommon.
Would not be
it's
uncommon.
not uncommon for us.
5 days.
Yeah.
In ED.
Mm-hmm.
We have had patients, it's not uncommon actually now for patients to complete their entire inpatient hospital experience within the emergency department and be discharged. To sort of, you know, again, I always come back to the Northern Ireland versus everywhere else. I was at our college conference in Birmingham and we talked about the OnCork study. And there were, you know, they talked about specific case examples, and the Northern Ireland was referenced where they talked about a case where somebody was in ED, they went for an endoscopy, which is a camera test, had the test, came back to the ED corridor and was then discharged, and that was audible gasps in the room of colleagues in England. Some of the stuff that's happening here is simply incomprehensible to even our colleagues across the water who are screaming at how bad they are, you know.
And yes, they're screaming about how bad we are, yet we are much, much worse than the rest of the UK. We are an outlier, we are many times worse. And all the time, reading this report, it jumps out again that attendances at ED have not increased significantly. So all the waits are happening not because there's an increased demand, they're happening because of systemic pressures elsewhere.
Yeah, I mean, what we would say is attendances have been relatively stable. Attendances have actually been very, very predictable. You know, we know roughly what numbers we're going to get through the door on a Monday. They're pretty constant throughout the week. We would say complexity of illness is changing. It's a sort of a testament to modern medicine that many conditions that were 20, 30 years ago were terminal are now chronic, and they need sort of specialist management, and when they invariably get a deterioration they need inpatient care. So I would say definitely, would you agree, Sarah, the complexity of the patient has changed, and again the demographic is changing as well, where a lot of our attendances are now frail elderly people, and that percentage is getting much larger and will get much larger over the next 10, 15 years.
You mentioned there just about the release to rescue and that you'd surveyed your members. You touched on it briefly there, saying that there were concerns and that overcrowding has worsened. Could you tell us a bit more about any concerns or anything that come up in the survey?
So specifically, we have had one of the reasons why to be totally straight, we really do support rapid ambulance offloads or timely ambulance offloads. This shouldn't even be a thing. We shouldn't even have to have a policy. If we have proper flow through our system, the ambulance would arrive and be offloaded when they come to the front door. But it's the understanding of why these delays happened in the first place. For why are patients ever waiting 8 to 10 hours? It's because there was nobody to bring them into in the emergency department. So we've brought in the release to rescue, and yes, there has been an improvement because we've been offloaded, but that's because of almost the patients waiting to go to the wards haven't changed. It's reconfiguration within departments. It's more patients been put onto chairs, to corridors. It's not really tackled what we think is the fundamental problem, which is the back door, and I always draw back to last year at Christmas time when my department didn't have that number of the sheer number. We offloaded ambulances as they arrived. We didn't have to have a policy to do that because we have flow. So we feel that we learnt this from England with W45, where the survey of the English ED said that overcrowding increased. Overcrowding increased while times got better. Incivility crept in between, conflict between ED teams and ambulance teams because they were trying to, get in two different directives. Thankfully, we haven't had the same reports of incivility. Thankfully, a lot of our colleagues, we work very closely with them, have done for a long time, and we all know what the issues are, so that hasn't been reported as an issue. But we are experiencing overcrowding. We did have a bit of a bump when it started. A lot of the trusts did quite, the figures were quite well, but we kind of felt that when we get into May, especially with 2 bank holidays, when things invariably slow down over a bank holiday, that will be when the pressure really starts to ramp up and where the sort of robustness of plans will be tested. And again, this week, from my experience on the floor, I'm certainly seeing that it has been tested very, very strongly.
That's what we're starting to see kind of across all of the emergency departments from speaking to colleagues. That's why we wanted to give it a few weeks to get a real idea. The first 2 weeks, obviously, there was a concerted effort to make sure that we could get flow and there was space in the hospital. And we're now coming into where the hospital discharges, as we said, are at 550. We're overcrowded. We're still trying to offload ambulances in to try and meet those targets. But then we also have our waiting room doors. So we have people coming in the front door. We aren't we're solely focusing on the ambulance target at the moment, so there needs to be a bit more balance. So we have other patients we need to consider coming through the department. So the overcrowding from our point of view hasn't gotten any better, and we're still seeing that these ambulances come in are just making the situation worse.
And you can just see it's a pressure cooker, it just builds and builds. Can I ask just any engagement that you've had with the department about the issues that were raised in this report? Anything so far?
We do meet SPPG once every 2 months, and we talk through the issues. We last met the Minister in January. And we have had engagement. Some of the individual MLAs have reached out to us and talked to us and met as a response of the report. So, that was one of the key things that we wanted from the report, was to get cross engagement across all the MLAs and all the different parts of the region, because it is a problem. I'm sure you've all have constituents who've been affected by this. The fact that we're getting this engagement and the fact that we're here today, it's really good for us to show that we are being heard.
Thank you. And just to talk about barriers, what barriers do you think are in the way of us progressing those recommendations and those reforms that need to happen?
I mean, we know that this can't be fixed overnight. We need, and we know that there's a major fiscal problem issue in Northern Ireland. We don't have the money just to throw at this to fix it. What we would like is a strategy, and it's going to be a multi-year strategy. It's going to be looking at, really needs to be tackling, in our opinion, social care. Now, we're not the experts in social care. We think the experts in social care and care homes, they need to be talking about what are their barriers to getting patients into the care home community and getting them out of hospital. So we think they need listened to as well. For us, again, is still the relentless focus on the front door. And, you know, I hear a lot, you know, everyone understands the issues with the back door and flow and things like that and getting people out. But every solution proposed to us seems to be a front door solution. And it's time and time again that's proven not to be what's needed, you know.
You have 500 odd medically fit patients that can't get out of hospital. You know, that's what we need to focus on. Okay, Orlia?
Thank you, Chair. Thanks very much for your comments so far. So yeah, I think that the statistics in your report around that 1,032 deaths is completely shocking. It's just a really scary thought that, you know, when people go down to the emergency departments to get help for whatever their illness or their issue is, it's just really frightening that can potentially lead to your death because you haven't been seen within the proper or appropriate time scale. So thank you so much for the work that you've put into this, and I hope this is picked up then with the urgency that it requires, because in many of the issues that we obviously speak about in the Health Committee, the majority of them are life and death, and you know, but in terms of this is an extremely it's an extremely urgent situation, because this is people that are going through the doors of emergency departments day in, day out, and we know that then many of them are dying, and even the difference in our stats from Britain is really interesting as well. And I think you made an important point in terms of even how the public would, you know, pick this, you know, this type of news up, because you might just take for granted that this is an issue impacting, you know, right across. But the fact that it's 1 in 3 of our patients are actually experiencing corridor care compared to 1 in 5 across the water, that's a really stark difference. So how are we responding? How's our system responding to that? So thank you for the work that you've put into this. Just in terms of then those deaths, now you mightn't have this level of breakdown, but even the evidence that you are picking up around the impact that these weights are having on people, and then potentially the people that are losing their lives. I'm thinking about people in crisis or with mental illness, and if you have any assessment on how it's affecting that cohort of people specifically, and you will know that there has been really a real desperate situation took place recently, and I'm just thinking, you know, how often is that happening? How often? So are these issues, have you any assessment in terms of how these weights being dealt with, you know, sitting on a chair? Or we know that emergency departments aren't the appropriate spaces anyway for someone that's in mental health crisis or with mental health illness, addictions, dual diagnosis. So have you any assessment on that issue?
We are seeing that with the lack of beds as well for those patients. We are considered a place of safety for patients who may have been seen in the community by a mental health team when a decision is that they need an admission or need an assessment. So they would be some of the patients that we would who would experience the longest waits within our emergency department. And as you've probably all been in A&E, it's 24/7, it's bright, there's no windows, it's noisy, it's overstimulating, and it's not an appropriate environment for these patients who can be in quite a fragile state. So we have been trying to do some work with the kind of mental health team, but we need to look at that going forward about how to develop their capacity and where it would be appropriate for them to be assessed. Because really, as a place of safety, when we're so overcrowded, it doesn't work for them whenever they're being sent up. So I think kind of going forward, looking at that, it's going to have to be kind of input, kind of multidisciplinary between the mental health team, emergency medicine services, social care, by developing community pathways and looking at that direct access. Now, a lot of them, they will try that, and it might not always be to bed levels that they're available, but then the default, as is with most of the systems, is to come to the emergency department. We are that safety net for the system, and I think we're at the symptom that the system isn't working, because we can see at 137% occupancy rate, how can we deliver the timely and efficient care that people need? If you think of the wards, We have wards in the middle that we're trying to work around and deliver care to these patients who are on chairs or on trolleys in non-clinical spaces with no access to, say, oxygen ports or medication and staff, and we're having to move people around in those kind of times of crisis when somebody becomes unwell. So we are seeing that across all the specialties in mental health. Obviously, there's a lot of focus on it at the moment.
And I suppose that was actually my next question, was around how you try and look at some solutions that can help ease these pressures. So I know, of course, the discharge problem is probably the main one, the biggest one that you're facing. But see, going back to the issue of the mental health and how you can try and, I suppose, try and support some of those people in a better way and reduce those waits. I don't know if you've looked at the PATH project that they're running in the Mater Hospital in North Belfast, and just that, you know, I was really impressed by that in terms of how they're taking people. It's that multi-agency approach, but then they're able to sort of deal with, you know, with those individuals in a more appropriate space and actually get a lot of them discharged before they even need to go on to take a bed. So, but I'm sure you're obviously involved in, you know,
and delivering
taking
that,
into
and that's
account
that kind
all
of
those.
multidisciplinary approach of working together about where these people are best served to be cared for and looked after. But that's kind of one example that doesn't exist throughout all of kind of across Northern Ireland, you know. So again, it's confusing for patients who get different services in different hospitals because it's not kind of standardised approach.
No, absolutely, and I totally agree with that, and that's the problem. It's you know, if we're going to try and invest and find solutions for these problems, then it is important that you're consistent right across all of our trust areas. So
makes it clearer for patients about they know how to access services and they know what's available to them, because there's some of that is kind of confusing for patients as well.
And it must be awful for the staff as well, even just you explaining how you know, practically it works on the ward where people are moving about on chairs and they don't have access to the proper you know, medical equipment that they might need. Like, I can't imagine getting into your day's work every day or the start of every shift and going into that pressurised system for you as a
And it is for the staff.
worker.
We all know the staff work very hard, but you think of that constant noise level and constant stuff. So for patients, but it has effect on the staff. We're not delivering the care that we would like to be delivering to these patients, and that's hard when you're trying to do your best, but we're being limited by what's available to you because of the kind of conditions that we're working in.
No, of course. And then just finally, just on the release to rescue, issue, you know, the chair had touched on it, and we did have an assembly debate, I think, Colin, keep me right, I think, opposition day, on the W45, the England model. So just if there's, I know that I think coming out of that, the Minister was then going to go away and look at, and the release to rescue obviously is one of those ways he's trying to, you know, reduce the time, the ambulance handover times. But so if that type of initiative was to be expanded, increased, just how would, you know, what would your feedback? Do you think that we're not ready for it, or, you know, what would be your assessment?
Not without the addressing the tackle. It's the fundamental issue of why ambulance delays occur is because of overcrowding. You know, most of our departments have what's commissioned as an ambulance triage area. So how they're meant to work is when the ambulance arrives, they're offloaded, they're brought into that area, they're triaged, they get their initial investigations, and they move into the main department. Some of our patients who arrive are in that ambulance triage area for 24, 48 hours after they're admitted. So it doesn't function as the way it's supposed to. So without actually addressing the reasons why the delays occur, just sort of saying that we're going to push it down to 45 minutes or 2 hours without actually tackling the fundamental cause is not going to, it might make the numbers look better, but it's actually going to cause, in our opinion, harm to the patients already in the department, because they're just going to be squeezed even further onto corridors, escalation spaces and things like that. And as I say, you know, I talk about escalation spaces in our departments, you know, again on the SPPG website, you know, they always report the number of non-commissioned or unfunded beds that are in upscale, and there's over 200 at the minute as well. So that's people not in corridors, in corridors and floor spaces, on wards as well. So, you know, I really think without tackling the fundamental issue, it's just not going to. It may look good on statistically, but it's just not going to be good for patients.
And yeah, I've heard from multiple staff members who are very, very concerned about the upsurge in those escalation beds or corridor beds, just patients lying in the corridor with a screen around them and no dignity. And there seems to be more and more of them on wards now. And they've seemed to be been there all year, effectively. So,
Nuala?
Thank you very much for coming along. It's rather scary, to be perfectly honest, when you do hear those figures, the excess deaths of 1,000, and we have spoken about it in the chamber before. As MLAs, we did bring the Minister to the chamber for an urgent oral question on the issue, because it is quite a stark figure actually when you think about it. But whenever you say as well about the overcrowding of A&E, could you give us a bit of a flavour as to what that looks like for you as a clinician trying to go about what should be an ordinary working day, and how that impacts on your day?
So I suppose you're coming into like an overcrowded department already. You have all your patients who are already there. You might be under the care of other specialties, but they're on the floor in front of us, and it's the nursing staff within the emergency department who are providing their care. We then have the front door of people walking in, and the ambulance is coming all day. So we have a finite number of staff who are trying to care for all these patients going in. So we're trying to make it as safe as possible. So we have patients in cubicles, patients in chairs, patients in the middle of the floor. With the increase in population, we have a lot of elderly patients who are non-mobile, who have increased kind of complex needs. So not just their medical needs, but their social needs for washing, dressing, toileting. So that's kind of on the nursing staff trying to care for them during the day. We then have every area which is already over capacity, and we have emergencies arriving through the front door that we need to get in immediately. So on a standard day, you're trying to see who's fit to move from what space to what space. So for an unwell patient coming in that you need a resus space, you might end up having to move 4 patients around the department to get a patient to bed space and where they need to be, because those patients aren't flowing out of the department to create kind of capacity for us. Then also comes in is that the doctors, the medical staff are coming in trying to see patients. We have limited cubicle space then available to see patients because there's already occupied by patients who need to be at oxygen ports. So we're trying to find any kind of corner or any space, trying to provide some privacy to have a conversation, to examine a patient and thinking about their journey through the emergency department as well. A lot of them, as we can see, have long waits who've already been sitting potentially in the waiting room or in a cubicle waiting to be seen. So we're trying to find time and space for them while also thinking there's lots of other people coming in at the same time. So it's quite stressful, because we already alluded to earlier, it's extremely noisy all the time when everything's going on. So for patients then are already kind of distressed by that. And then you've got a patient that you want to admit and you're looking around and you're trying to speak to your nurse in charge, finding out where you're physically going to put them. And that's daily. So corridor care isn't kind of a thing. Corridor care is just our everyday. It's what we do in the emergency department.
It doesn't seem, it's not very dignified for the patient, and it doesn't seem dignified for staff either, to be honest. And do you have, at the minute, are you being provided with additional nursing staff to help look after these patients who are now essentially inpatients?
So across the departments, we do the risk assessment as you're looking about your designated space and so how many patients are in, and you try to staff your department appropriately with nurses who are allocated to each area. But working in this environment, you can imagine our recruitment and retention numbers aren't great. So although we have minimum staffing numbers to try and keep everything safe, we don't always meet those numbers of staff in each day.
So you don't always meet the number of minimum staff required?
Yeah.
And is that element, the element of overcrowding, the element of waiting, is that what is added to the 1,000 excess deaths? Like how did we get to that point?
So, you could go any day, just for example, you could have an area or an escalation area or corridor, and one day it could have up to 20 patients, 20 admissions in that corridor, and you would have 2 nurses allocated to that area, so that's 1 nurse per 10 patients. And one day you come in, it could be maybe 4 or 5, and you can have 2 nurses allocated between 5 patients. So whenever things get really, really stretched, these patients that are coming into these spaces, they're 24 hours into their acute illness in hospital. They're not. Some of them are not necessarily. They're still maybe they haven't got their diagnosis yet. They're waiting on urgent medications, urgent treatments, and they have to be observed. Need to be in heart monitors, things like that. Whenever the resources stretch so thin, it's very, very difficult to, you want to deliver your medications timely, you want to deliver your pain relief timely. I've been made aware of cases where people have had pressure sores develop from sitting on chairs in corridors. it's sort of the basic things like that. And when you take all those little small things, it's not necessarily one big miss which causes these. It's all these small factors when you add together. In people who are very often sick, frail, vulnerable, it's enough to cause serious harm. And just what you're saying there about what it's. I mean, I find it really hard to come in because every day I look down a corridor and I see people sitting there and I can't look them in the eye anymore because I know it's wrong. Every single person in the room knows it's wrong, and there's nothing you can say, to say that this is acceptable, and it's because it's just not.
And do people die in the NE, in the NE waiting or in the corridor? I mean, when I think 1,000 deaths, I thought, well, where are they happening? Do we have people that are dying in our corridors? And I'm assuming they're not able to avail of what the usual kind of care would be. It's more than maybe they're sitting. Say some of them are very early stages of their illness and diagnosis, where we're still maybe doing investigations, workup. They take a turn in the corridor, become acutely ill, and we try to treat them. But whenever you look back in hindsight, maybe there was something else you could have done a bit earlier. The other big one is the waiting room. So of the patients that come in that are waiting for 12, 18 hours at times to be seen, a very large part of myself and Sarah's job is constantly looking at that waiting room to pick out as we call the zebra amongst the horses, who is that one patient that's a ticking time bomb sitting there that we need to get in. It's really, really hard, and there have been outcomes where people have collapsed in the waiting room, have had really and died. And that's happened. And it's when you bring all those factors together. If you're at a department with 140% capacity, you've basically got 2 wards of patients in your A&E, and then you're having to sort of anticipate we have another 250 to 300 people arriving today to see them with no capacity. It's not surprising if things start to fall apart and harm happens. So that's kind of that's where a lot of this comes from, and it's very, very difficult. I wouldn't be able to work in it myself, so you do amazing work to actually just be able to even show up every day if that's what you're working in. One of the issues that we've raised with the department is the standard mortality ratio. It's not really incorporated. And he has the minister has basically said no here. But can you speak a little bit about
it's about our standard 172? Yeah. So this was published on a study a number of years ago, and it was sort of a statistical analysis undertaken, and it factored in all the variables that with regards to normal emergency care working, and they basically looked at the correlation between length of stay in ED with mortality, and they found that the number needed to harm was 72 people waiting that length of time. You'll have one person have an adverse event, and that's where we got the number from. So that's kind of been applied to our own statistics and figures. The worrying thing for me is that study was done a few years ago on 8 to 12 hours, when really what we have now of 24, 48 hours didn't exist. I can't say for definite whether that causes an exponential increase because it's not been studied, but logic would suggest that it's certainly not going to improve from having an increased length of stay. So yes, it's a useful statistic of where we are and how we're performing as a region. It's also useful because we can look at across our colleagues and see, we are really outlying compared to everybody else, and ask ourselves, why is that? So that's for us, that's where the beneficial of the standard mortality ratio comes from.
Okay, that is helpful, and I think it is important to highlight again that it's not that it's as bad everywhere else. We are actually worse, and we need to get a handle of it, and it's a difficult job to be doing that, but it has to be done. And do you see anything that is helping at the minute? I mean, plenty of us raised in the chamber about the reducing the handover times. It's just going to clog the system on the other end. It's not actually going to make the system better. What about phone first? Is that making a difference? What about people who go to NE who don't really need to go in NE? Perhaps they can't get access to their GPs. Is there anything that you see is helping or making worse?
I think, as we've said before, we agree with the ambulance offload policy because we want to get patients in as quick as possible. We want to get those ambulances out into the community again because we see the effects of those patients who can't get an ambulance and then a relative's driving them up, or they're waiting 24 hours lying at home on a floor, and we see the harm that's coming to them. But that can't be done kind of in isolation without addressing everything first. With regards to Phone First coming through, there aren't many other alternatives, and I think when the people are being signposted and given advice, we don't really suppose think of unreasonable attendances. The reason people are coming to us is because they've got nowhere else to really go to get that advice, and it might not be an emergency, or it might not be where they should be coming to, but if they can't get it elsewhere, we have become, as I said, that safety net. So looking at kind of developing, whether it is GP appointments, urgent care centres, that kind of thing all needs to be to give patients more of a somewhere else to go, really, rather than just the emergency department.
Look, thank you very much for coming today, and hopefully, next year we can reduce that number, because we know that you are doing everything that you possibly can.
Okay. Thank you. Linda?
Can you hear me, Chair?
Yep.
Thank you very much for the presentation. I would like to be able to say that I'm shocked at the report, but I'm not, because truthfully, it's good to have it down there in black and white, and it supports what we've all been saying, what we all already knew, that the problem is the back door, the problem is flow, the problem is social care, the problem is not doing anything to address the issues around social care. And I accept what you've just said around the ambulance times and wanting to get people into the hospital. And I think, to be fair, there is an argument for that, because as you outlined, when you go out into the triage area, you're looking to see who's the ticking time bomb. But if they're not in the room, then they have no chance of being picked up. So I think it is important in that sense, but it's pretty useless exercise without dealing with the stuff at the other end. And I think that's really, Chair, where we need to put our focus and keep our focus, because we've heard this from every single clinician who works in hospitals, and we've heard it from everybody who provides the care, and we've heard it from families, and we've heard it from people who need care, that actually where they're being failed is the provision of that care at home. So I know there was some funding went towards like hospital at home or acute care at home. Different places call it different things. I think we also need to follow up and find out, what, if that funding has really helped to ease the pressure, or has kept any significant numbers of people away from the doors of our A&Es, but more importantly than away from the doors of our A&Es, it's have kept them out of the hospital beds, have kept them at home, where they will be much better served in terms of dealing with their health issues, and not putting them into a hospital setting where very, very many of them deteriorate. And I know, Orlea has raised about those in mental health distress and the difficulties they have in A&Es, but also, I mean, last week was Dementia Week. Somebody with dementia being in an A&E is just, it must be the most horrific experience for the people who have to sit with them, and that's staff and families. So, and I think that's one of the things we've probably missed in the conversation so far, is, what kind of support and services are there for your staff and for their well-being, because they're not just dealing with the numbers of patients coming through, they're dealing with people dying, they're dealing with those people's families, which is very often much more difficult than dealing with the patient or the health issues. So I'd like to get a wee bit of a sense of that. And I mean, 4 years ago, I went to Craigavon A&E department, and the senior clinician there said to me, the one thing I'm going to ask is, please don't extend the A&E. That's not what we need. And you're saying the same thing today. So none of that has changed. But the other thing that hasn't changed, and I do want to give you some reassurance around this, because you said when you first came in your opening remarks, what you want is cross-party support in terms of backing your calls and your recommendations. You have it. We've all been saying these things. I mean, you very, very much have it. And we've been saying this to the Minister consistently and to the departmental officials, that what is needed now is a proper strategy around social care. Something that's really going to, instead of just kind of having half-hearted, we'll do a bit here and a bit there. It's just not working. It's not working. And until that's dealt with, unfortunately, you're the ones who are going to suffer. And I think, Chair, that's where our focus actually needs to be and coming out of this meeting. It's not what our emergency departments are doing, because they're doing it. They're doing everything they can do. In fact, they're doing way more than they should be doing. The problem is at the other end. And unless we address that, the problem is going to remain the same and get consistently worse. So I think that's where we need to have our focus. Sorry, it was quite a bit to throw at you, but you have given the answers. You've actually given us all the answers. There's not a lot of questions we can ask you, because you've actually given us the answers already. And it's up to us as a committee now to hold the department to account about what they're failing to do.
I think what I would say, your first point about support for staff, is that it is something we have recognised as a college that does need to happen. I know some trusts, the staff can avail of psychological support. There is a sort of a methodology now around debriefing that's very well established regarding for very, very difficult cases. So there are some mechanisms in place. It's interesting you raise that point, because just last week, I know this applies specifically to doctors, but I was asked would RChem co-sign a letter to the Chief Medical Officer from an organisation called Doctors in Distress, which is essentially a body where for providing sort of help to doctors who enter into difficulty. And I was actually quite surprised to learn that this exists in England, Wales and Scotland, but there's no provision in Northern Ireland for it at all. So ourselves and a lot of other Royal Colleges organisations have co-signed this letter, which was sent, I believe, last week to the Chief Medical Officer. So we do recognise, and what the impact on staff is absolutely massive in terms of sickness and things like that there, and the sort of psychological aspects. So whatever can be given to help, we definitely welcome it.
Yeah, I mean, I think it is important. Unfortunately, I have a very recent experience of seeing the trauma that staff suffer, particularly at the sudden death of a young person. So I do think it's important that we follow that up as well, Chair, with the Chief Medical Officer to see what the response is going to be, that's going back to the Royal Colleges in relation to that, and maybe even request a copy of that response for the committee.
Yep, absolutely. Happy enough to request that. Anything else, Linda? Are you?
Yeah, no, Chair. That's everything. I mean, as I said, we've been given the answers here today, and they're the same answers that we've been repeatedly given. It's how we actually hold the department to account now to make sure that they deliver something better than what they have been.
Thank you, Linda. Diane?
Yes, thank you, Chair. Apologies that I wasn't here for your presentation. I had to take a phone call. I have read this and I've spoken on it on a number of occasions. I do actually think this is really, and I use the word advisedly, quite catastrophic to read. That I think, was it last year, that there were over 1,000 excess deaths in our emergency departments. And people, I'm not sure that people, the consciousness of the public, have grasped the actual reality of that. That is a shocking statistic. So I suppose, first of all, have you comparable statistics for England, Scotland, Wales and the Republic of Ireland?
So yes, the college did conduct, they applied the same metric across the figures across the other devolved nations. I don't have them to hand, but what I do know, because I actually wrote an editorial on it recently, was when you look at the population of Scotland and their predicted excess deaths, and you compare our population rate, we are 4 times higher than Scotland. They were, I think, we worked out at something nearly around 500 per million, and Scotland was about 140 per million. So again, that was sort of something I've consistently tried. That's kind of what I'm really trying to get into the public domain and get the public to understand, is that because there is fatigue about emergency care and the perpetual crisis, is that we are the outlier. We're not comparable with Scotland. If we got to where Scotland was, that would be actually a massive improvement compared to what we have now, and that's sort of the message that we're trying to get out.
In Scotland, England and Wales, given that they also have a problem, what are the specific actions they're taking? We know and appreciate, and I'm going to come on to the issue of sort of those people who are fit to go home, want to go home but cannot go home. So what specific actions are they taking to try to alleviate that problem? Is it the ambulance issue? Is it, what are the specific actions that they're taking?
Regarding the social care side, honestly, I'm not sure whether it's just a pure case of funding and finances. It could be that. I know that they have introduced a lot of stuff in terms of called SDECs, which is same-day emergency care. This is a wee bit still in its infancy in Northern Ireland. They talk about ambulatory units. If some of you walked around the departments, some of the English ones are very well established, what's called SDECs, where primary care can refer in to those to be seen by same-day specialists and things like that. The mental health system works differently over there in terms of their legislation and their laws compared to ours. So not every, we have whenever the PSNI would deem somebody under Article 130, the default place of safety is the emergency department. In England, that actually can be what's called a place of safety, or they call it a section 136, which is they have a suite, which is not necessarily in the emergency department. So they do little things differently to us. As to how the gap has got so big, I honestly can't pinpoint one particular aspect of why that happens, because social care is a problem in England and the rest of them, and they do, because whenever I go nationally to the executive, it's highlighted by all my other colleagues. It's just I can't quite grasp why it's got so large here, whether it is purely funding, I don't know.
I was over at Craigavon a couple of Mondays ago with colleagues, and we were discussing the issue of social care. And I think they said on that day there were about 700, the equivalent of about 750 care packages that they currently couldn't meet. And that didn't include those people who, for example, had actually come out of hospital but had gone into a residential place, not of their choosing, but because they still couldn't get a care package. And I continuously made the point that, I mean, we spend money on the most expensive form of care, keeping people in a hospital bed, but not on a less expensive but more effective form of care, because keeping people in a hospital bed, every time anyone belonging to me has been in hospital, the idea is to get them home as quick as possible so they don't get further infection and so on. So, I mean, I never really understand the health economics of this. I mean, it doesn't seem to me to be a sensible provision. The other thing that I've been in the ambulatory unit, and they were developing a frail elderly unit which had a much more comprehensive service for those. Has that made, is that in any way widespread in Northern Ireland, and if so, has it made any difference?
It's still very much in it's a good service. It's developed still much in its infancy. It is still very much office hours, because of the resource and staff. It's one thing that we highlighted, or certainly I highlighted whenever we met the regional SDEC group, is that the sort of frailty and fit services are really, really important. One of the issues we have, I've been told, is that we just don't have the consultants coming out of training here at the minute to actually meet demand, to really upscale that service into what it needs. But for the patients that are suitable for it is great in that it can get them turned around. It's a multidisciplinary based approach,
holistic service,
care, and it can prevent an admission and discharge. It's scaling it up is the thing, and beyond.
Do you believe? I mean, this is your day-to-day work. Do you believe that scaling that up would help
I think it won't solve it, but it would certainly help.
Yeah, I think it would help with kind of experience of it. We're trying to get these patients earlier in their journey in the emergency department,
Yes.
so trying to select the right population of these patients coming through, so there's not long waits out the front and
Yes.
sitting waiting for assessment. If they can get in and get seen for their medical and their multidisciplinary needs at the same time. Also then in daylight hours, if you're getting them started earlier in the day, to try and get those care packages, or working with family that they could go home until something's in place the next day. So it definitely does have its value.
The other issue would be that if you're elderly and you're admitted and you wait in ED or a hospital for days or hours, you get deconditioning. So
Yes.
you might lose what independence you have, and the quicker you can get involved with that, you have much more chance of getting that patient discharged back to where they were before they came in.
Do you worry about safe discharge?
Yes, I do.
Are you? I mean, I came across an issue the other day. I was talking to some of my local GPs who are also then become temporarily responsible for some of the folk who are maybe put into a particular residential placement. Southern Trust has a number of these, so I speak about the Southern Trust. And they're put into a residential, they become the temporary charge of a local GP, but that local GP doesn't have access to all of their information, and they were expressing concern about the safety of the discharge process. Is that something that worries you?
It does, because we would very often see failed discharges come back. You know, someone who's been discharged
Quite quickly again.
sometimes same day. Someone who's been in hospital discharged and has come back hours later because of either another event that's happened, or the care meds can't be met. You know, and I have, you know, as aggressive as we can be as emergency physicians to try and keep as many people out of hospital. I've had to admit patients before who I've seen purely because I know that they're not safe to go home, and they need that MDT care input and things like that. And you do, again, I know our focus is very much on, you know, the back door, but and the worry is that translates into pressure to get get people out of hospital before their needs are met, and that's where that comes back. So it boils down to, you know, it has to be safe, it has to be resourced, and it has to be a strategic plan of how we're going to achieve that safely.
Okay, I think that I hadn't considered that before, and the more I thought about it, I think that's quite worrying, because getting people out just to simply get them out, but not out safely, is really important. I suppose I just throw this in there because I haven't heard it discussed before. I did ask a question about the issue of consultant cover in EDs, particularly at weekends. And again, you know, on the basis that all politics is local, and I was interested in the issue in the Craigavon and the Southern Trust. And consultant cover, it says Craigavon Area Hospital, consultant cover ranges from 36 to 50 hours on weekdays. Fair enough. I don't know, that's an ED, I don't know what that, you know, how many that equates to at any particular time. But goes to 8 to 16 hours at weekends.
So
Is that an issue that we should all, I mean, in my head, and I'm not a clinician, so I'm asking for advice from you. Is in my head, if there's someone who can make a senior decision, that patient should be able to be moved on. So is there a case in this whole picture of trying to move people out of ED quicker and to have them seen quicker, to have more senior decision making?
So, speaking as that department you're referring to, we.
I mean, it's the same. I mean, in everyone. I mean, Daisy Hill goes down to 8 hours at weekends. This isn't.
Yeah.
This is a trend across all.
So
you don't have to speak to anyone.
No, it's fine. I mean, one of the good things that has happened, and it was credit to the Minister for acting this, was about a year and a half ago, we had a crisis where we had a large number of senior registrars exiting training, who were ready to be consultants, and we didn't have jobs for them. and as a result, many of those doctors have now been recruited into consultant posts, and as a consequence of that, many of our departments have now extended their consultant cover hours. You know, mine, to speak with my own, mine's gone from we now have 2 consultants on every day, every weekend now, and we used to provide 8-hour cover. It's now up to 11-hour cover. There is a terms and conditions issue with regards to, you know, how often how you do that and things.
Yes,
It's more complicated.
This is a difficult thing to actually organise.
Yeah,
I accept that.
But
I'm just asking the principle. Would it be? Is it right to say that this would more senior decision making would actually move people on in a quicker way?
It can certainly speed up decision making in terms of management plan and treatment, but ultimately if the decision is made to admit, I'm still at the mercy of when that bed becomes available.
Yes,
I don't have
I
we don't
accept
have control
that entirely. I do. I just think it's something maybe worth exploring. And I mean, I have no desire to get into terms and conditions or any of it. I'm just talking about the concept of it. You know, how if you explored that further, if we had more people available, would that actually also help us in those situations? Except if there isn't a bed, you're still stuck in ED.
Yeah.
We
published 2-3 years ago our workforce census from Markham for Northern Ireland, which looked at our emergency medicine staff as a whole, and we made recommendations based on that, and that actually led to some of the consultant recruitment that we got. We do as a college we would recommend that each department would have 1 consultant per 4,000 attendances per year. I think with the last round of recruitment that brought us down to about 1 per 7,000, which was considerably better from where we were before.
Still not where you should be.
It's not ideally, but it's actually pretty much, it's getting a bit on par with where the rest of the UK is. We were again the outlier before, but we've improved in that. I am aware that there is a body of work been undertaken by the department, a workforce review, strategy review, and emergency medicine is one of them, of which they're looking at, you know, where we need to go in terms of recruitment, in terms of training numbers over the next number of years.
And are you involved in that?
We haven't been directly involved in that, but we know that some of our information has been, some of our college information that we've published has been looked at as part of it.
The data that we've collected.
We're told we're about in this committee to get legislation on safer staffing. Have you been involved in that?
No, that's the first I've heard of it.
Not at all?
No, that's the first I've heard of this legislation on safer staffing.
Good plan. Right. Hey. That's a bit of a clanger at the end. Can I just say thank you? I mean, I, like everybody here, either have occasion to go to ED, either with family, friends, or to just talk to my local consultants. I can't imagine how they do the job they do. And I do sincerely want to say thank you.
Thank you. Colin?
Thank you, Sharon. Thank you for the presentation and the report. I think it lays bare exactly some of the problems that we face, and in a positive way, if we simply look at the problems that you're facing and then deal with them in isolation, we're not fixing the problem, because it is a conveyor belt right from the person is sick right until they get better. And if at any point along that process we're backing up, then we're creating dangers for people. And I know that can sort of create difficulties at the different pinch points. And I'm really taken again with this issue of the number of people that are waiting to be discharged, because I've done a quick check and I think we have 4,000 hospital beds across our 9 acute hospitals, and if we have 550 people waiting to be discharged, that's 1 in 8 beds where there's actually somebody in it that should be at home. And also that, which if you go from home to the hospital bed, to the ward that they're on, down to the emergency department, it's not just you that's dealing with that problem. And I think that there may be, I've often thought this, that if you have 550 people that are ready to be discharged, the domiciliary care that they require would be relatively minimal, as in it might be 2 visits in the day. But yet you've got staff on a ward that maybe have 12 beds, but you could have if you've, say for example, 16 beds, where there must be 2 or 3 people that are ready to go home. So I've often wondered, is there not a way that there could be a reconfiguration of the staffing within the hospital to release staff down to yourselves, where you're literally looking at a war zone? I mean, you're looking at people lining up corridors and can't be dealt with, and yet upstairs in the rest of the hospital there could be anything up with nine hospitals and 550 patients, just taking the average. You know, there could be 50 or 60 patients up in there that don't really require an awful lot of care because they're well enough to go home. And I was just wondering, this could be a medical naivety, so hit me with it. But if you've got patients that are in the ED that are ready to go up onto the ward, if their emergency care has been managed and stabilised that they're ready to go up on the ward, if for the sake of argument just next door they opened up a unit with 6 or 7 beds in it that you could just simply move them into, because they don't require emergency care from a consultant that's got 20, 30 years experience, but you've got people on a corridor that you can't bring in to treat them. I'm just wondering, although it should never be the overall solution, but is there a flow solution that could actually be found, that if we adjusted how we dealt with the flow, that it could actually allow the expertise to get to those that actually need it the most? Because that was kind of some of the approach that I had taken with the ambulance issue. And this is one of the ones that's going to just play in my heart forever. I had a constituent that wanted to remain nameless, but on the 6th of April, they called for an ambulance at 9:25 in the morning. The ambulance didn't come for 24 hours. They died a couple of hours later. Now, 2 weeks later, we brought in a system where they would not have had to have waited 12 hours, 24 hours on an ambulance. And I've no doubt that that patient is dead, because if it had have been 3 weeks later that they had their incident, they would have been getting picked up much, much earlier, because the release to rescue would have let them out. So the release to rescue isn't a punishment on you, and it never should be. And I welcome where you're saying that actually it's a system, you understand the principle of it, but it also is not a solution if it gives you a problem. And we have to just look at how we manage that. But I'm definitely just struck by the concept of there being, 1 in 8 beds has been taken by somebody that potentially, and I know this narrows it down to its bottom level, and I say it with that health warning to it, but somebody that might need tea and toast brought to them at 8 o'clock in the morning, might need help with getting dressed at 11 o'clock, may need afternoon tea at 4 o'clock, and may need some assistance with washing at 9 o'clock at night, but they're actually holding up a bed which you can't send somebody up to, which means that you can't deal with somebody that maybe is having a serious health episode. So it just feels like we've got, even though the flow is wrong, it just feels like within the flow we've got it wrong as well. So are there things that could be done within the flow that would alleviate some of the issues? And is there anything that those patients that you have stabilised but are taking up a cubicle or taking up a chair or taking up other things, is there somewhere that they could be safely moved to before they get to their ward that would then allow to free up your space?
We don't have the space for that at the moment. I think we had kind of expanded out into escalation areas and wards across, but again, you need more staff to staff that in another area. And as well as us, we alluded to kind of earlier that the patients have patients on corridor beds who are already kind of what we would call them boarding up there of moves. So we do try to identify who are the patients that are safe to go to a corridor bed upstairs, which isn't ideal, but when we need space. So to my knowledge, where I work, and I've been big to other, I don't think there is another temporary area available at the moment, like that transition kind of step down from us to somewhere else until they get to the ward. Because again, it's just another place to put people to wait to actually get up into the ward. I don't know if you think.
You know what? I mean, what the wards have done is, and it's reflected in the figures, is that if someone needs to get up to a ward bed as a priority, they move somebody onto the corridor of the ward, because there's no places to put them. I know in some trusts, one of the escalation spaces would be like recovery in the theatre suite, to put beds in there, and it's a temporising measure. But again, that has then an impact on the flow of surgery in the hospital as well. So I think a lot of area and space that could be utilised is being used. We have, there's areas about ambulatory and putting admissions in the ambulatory. It seems like it's a really tempting short fix to do at the time, but actually what you do is you compound the problem the following day when you're going to need that to see new patients that are coming in. One interesting point that actually you do make about the sort of the nursing cohorts and the sort of nursing ratios is that we would sort of say we have in the emergency department, maybe 20, 30 patients waiting admission who are in a corridor. Those patients are at the early part of their illness. There's still potential for deterioration, diagnostic doubt. They're potentially sicker than maybe patients who have been in hospital for 2 or 3 weeks upstairs. And it kind of seems like the acuity shift is very, very heavily concentrated. And we would say that we call it the cohort of risk is down in the emergency department, where we're caring for the sickest people in the hospital in the most inappropriate areas, and that might be where you come from, where the balance could be redressed with that. How you do that, but with basically no capacity anywhere else in the actual hospital site, is really difficult. But as a principle, yes.
Yeah. And I think to be honest, if we've got 1 in 8 people that are fit to go home but can't, and we've got 1,000 people a year dying because they're not getting timely treatment, for example, in the emergency department, and we had people in the community dying because they couldn't get access to ambulances, you have to wonder, at what stage do you declare this an emergency? And it actually, the response that needs to be to address that may be a bit off the wall in places, but it may be an inconvenience to somebody for a week or 2 while they get their care stabilised. But if it allows people to get the appropriate care that they need to be able to stay alive, I think we really just as a society need to take that step back and say, well, what is appropriate? Because is it appropriate just to sit back and think 1,000 people a year dying is okay? Or do we have to look at, I've suggested mad ideas like within reach of a hospital, have a hotel. Somebody moves out of, if they're fit to go home, move them into a hotel. Who's going to say no to being put up in a hotel for a week if they get that cup of tea and that wash and that whatever it is in it? But somewhere that you can just move people out to. I don't think it would cost a huge amount of money to run that, but it would free up the beds. But I think the problem is that the system is scared. That actually if you do that, then you just provide another place with 100 beds that you fill up, and then all of a sudden you're still dealing with a backlog down where you are and there's nowhere else for them to go to. But I think unless we get that sense of needing an emergency, declaring it an emergency, until we take that approach, I don't think you are going to get the help that you need to be able to do the work that you're doing in the department. And I know I had done a paper on the W45, the Race to Rescue. It absolutely contained within it additional staff for the emergency department. That there was those additional nursing staff at a senior grade that could take some of that decision making that was suggested, because often senior decision makers will very quickly say that person's fine, move them on, that person's fine, they don't need all the tests. There are ways of managing it from there. I've been over in England where I've seen a pilot project where there was a GP at key times put inside emergency department to walk around and say, you could be seen, here's an appointment, off you go. You could be seen in a GP practice, here's an appointment and off you go. Some small tweaks like that could clear 10% or 15% of your waiting room away, which allows you to focus in on what you're doing. There are things that we could do. I just feel like at the minute we're just doing none of it, but we're just leaving you to face the pressure. So I hope this presentation and the questions we ask will allow you to continue that pressure on to try and help you with the work that you do. Thank you. That was more of a rant than a question, but we'll leave it at that. Thank you, Chair.
Thank you, Colin. And just to point out, I think I would get killed if I didn't point out the overcrowding that you're talking about also exists in the wards, where we have corridors full of patients who are backed up end to end, predominantly frail elderly patients with a lot of very high level care needs. So that's typically the type of patients who would be waiting.
And so a case I had where they don't even have access to toilets whenever they're in a scenario like that, and that was a real problem for a constituent that I dealt with, an issue as well, but a real issue.
And I know that's an issue in A&E as well, when you have 1 or 2 public toilets and a huge amount of patients. Alan?
Thanks very much, Chair. Before I ask my questions, just record my appreciation and thanks for the work that all of your colleagues do in accident and emergency. A couple of things that we all seem to agree on around the table is, number one, that we would like to begin in every day to do the work that you're doing. And the second thing I think we're all agreed on is that we do need a strategy a social care strategy around easing the blockages at the back door of the flow. But if we did have a better flow, would that result in emptying the waiting rooms in accident emergency? Or would there still be a problem with the number of people coming through the front door? Some who maybe could go somewhere else, go to a pharmacy, go to their GP, go to out of hours, but they land in the accident emergency. So even if we did increase and improve, and it really would take a magic wand to get to where we want to get. It's going to be a very slow process, even if we have a strategy. But will it result in the waiting rooms emptying?
It will certainly improve it. The main reason being, the reason for the delays that we see in the packed waiting rooms is not necessarily demand. It's due to whenever we call the patient in to see them, we have nowhere to see them. We're scratching around trying to find a cubicle, a cupboard, a corridor with a screen pulled around it. It's all the evidence that we've had before is when we have flow and cubicle capacity, the actual flow of patients from the waiting room comes in a lot quicker. And with people, I always sort of, with people who, I don't like the term attending the emergency department inappropriately. I don't think anybody at the minute would voluntarily come to sit for 8 hours in ED with what we call a trivial illness. And those aren't the people, those aren't the patients that are causing the flow issues in our department. It takes me 5-10 minutes to see and assess a patient who could have been discharged and seen in the community. They're not. It's not an issue. It's the whenever someone's deemed need admission and they're frail and they come in and we have to find a space to accommodate, knowing they're going to be in ED for 24, 48 hours. So to answer your question, if we get flow and we get cubicle capacity, there's times I've got typically a bulk of our staff would be just around lunchtime. So the morning staff and then the afternoon, evening staff come in. We have doctors there, and the doctors are, you have maybe 5-6 doctors scrapping over one space to bring a patient in to see them. It just grinds the system down to a complete halt. Where if each of those doctors had a cubicle that they could bring a patient in, it would just turn over and flow much increase, and that would help the waiting room completely.
It would also decrease kind of the workload for our nursing staff caring for those patients, so that the patients we are seeing and we need some medications or discharge for home, that process would be sped up as well. So we would have freed up nursing hours to be able to do kind of other ED jobs that would create kind of flow out of the department for people who aren't being admitted.
So we're not making, that being the case, we're not really making the most efficient use of clinicians' time, then. There's an awful lot of your time that's spent looking for a space when you could be treating a patient. Just in relation to the shocking figures of how many people have died in a year in accident emergency, it does seem to suggest reports it's people that have waited more than 12 hours. Are those deaths a result of delayed diagnosis or delayed care or delayed medication, or is there an inevitability that people will die in accident emergencies, and it's not all attributable to the environment or the system? People will die. So it is that sort of 1,000 plus deaths. Does that include people that might have come from a really serious road accident and were so mortally injured that death was an inevitability? Would that be included in those figures, or is there any separation made in those figures?
There would be no separation for those particular scenarios. I mean, what I would say, we do get, in a situation like a road traffic accident with a major trauma, they would be managed, they would probably be going to an intensive care unit or theatre and leave the department quite quickly to get that definitive care. We do get a lot of patients who do come in who are sadly at terminal end of stage of their life, whether that would be from full nursing care or residential care. Many of them come in with, we would strongly suspect that they might come in with pneumonia, for example, and we would treat it, but we would strongly suspect that this will be a a life, a terminal event in that person. So while we don't specifically dial into those numbers, you're correct. There will be people who have inevitability about.
So there's a percentage of those.
There will be.
That £1,000 figure is maybe not as stark as.
Can I just come in there? My reading of it is that it's over 1,000 excess deaths
yes.
that are associated with people who waited longer than 12 hours.
Yes, you're correct. Sorry. Yes, Chair.
Longer than 12 hours in an overcrowded A&E. So this is excess deaths above.
Yes.
Above what would normally be expected,
Yes, I should have said that. Yes, you're correct. It's whenever they did the study, they factored in the variables of sort of predicted mortality of patients that would come in. Yes, so I should have clarified that. But you're right. There is a wider issue, and this has been discussed before, about advanced care planning in many patients. There was a campaign years ago about have the discussion. What is a patient's wishes? Have that discussion when they're able to communicate that. The last thing I think anybody wants is me jumping on their chest doing CPR as they're at the end of their life. So there is definitely a body of work in that, and that was sort of one of the things that was taken out of the big discussions that the Minister ran last year, was advanced care planning and sort of that issue.
Just a final question, and I'm sure this one probably cost you sleepless nights thinking about it. Sarah, you painted a picture there of and Michael's alluded to it as well, where you're hunting around the corridors looking for a broom cupboard, looking for anywhere. You can take a patient to give them a bit of dignity and privacy to try and extract from them what their issue is and make a diagnosis. And while you're doing all that, you've got this war zone noise going on in the background, people shouting, wailing, whatever, trolleys banging, and a nurse may be coming in as you're just about to start with your patient in front of you, handing you a file, could you sign off that medication for the last patient, and you're having to concentrate and read that and sign that and then deal with that patient. Is there any potential that environment could compromise clinical decisions? Could it interfere with
Yes, the
your
amount
clear
of interruptions.
thinking?
There's been studies done before about the amount of interruptions that we get on a daily basis. So there's been, over the years, different things for nurses on wards who are giving out medications that they wear kind of a bib that says, don't interrupt me, because we can see that when they're being interrupted and distracted from the task at hand, that errors and human error does happen. So that is kind of the risk working in that high pressure environment with so many things happening all the time. So that is the potential for risk in that, with so many people and so much happening all the time, and especially as senior decision makers, myself and Michael in the department, people are asking us a lot of questions all day long. There's constantly a queue. I think when you turn around, of people looking to speak to you, and I suppose that's part of our job, saying, can you give me a moment, and then your task prioritisation of what is urgent, what's an emergency, and what can wait for 5 minutes.
Certainly not
but for our junior staff,
for sure. Thank you. Thanks, sure.
Thank you, Alan. And I want to thank both of you for what I think has been an incredibly important briefing. Certainly ones, I know we went a bit longer today, but I think the quality of the questions and your answers was very high. Certainly something we need to hear. I want to agree with you, it's not acceptable. Absolutely not acceptable that this is happening, and I want to thank you for your clarity today. You've certainly spoke very clearly for your patients and for your staff members, so thank you, and for the work you do.
Thank you for inviting us here today. We really appreciate it. To talk to you.
And I can assure you we will be delving into this a lot deeper, so thank you.
Thank you. Thank you very much.
Thank you.
Thank you.
Okay, folks, just as a quick follow-up from something Diane was saying just about the comparison between Scotland and Northern Ireland. Scotland had 871 excess deaths in 2024, and they have a population nearly 3 times the size of ours. So they have 5.5 million people. We have 1.9 million people, and we had over 1,000 excess deaths. In Scotland, this was described as harrowing and heartbreaking. So we have 3 times worse.
It is actually, Chair, catastrophic, and for those who believe their loved one might have been impacted by that, it is beyond catastrophic.
And I think, sorry, go on.
No, it's fine. I was just going to suggest that we maybe ask for the officials who look after this in the department to come to the committee.
Yeah, that's a good idea.
So that we can ask them what they are doing to actually, and what's the strategy around it.
Well, as an emergency.
I think that's a very good idea. Now, we have sent the reports to the department for a response. We haven't got it back yet. And I think given the impact of the stuff we've heard today, I think that's probably a very good idea if everybody's happy. I know
if there's 1,000 odd people dying that are avoidable, and they're dying because this report says it's a 12-hour waits and all the rest of it, is there not here a huge crisis if people decided, families decided to take legal action against the department for neglect and causing their loved one's death by negligence, if that's the right word? I'm surprised that that's not factored in, that people aren't thinking about that, because we are a very litigation-led society, so we are.
It's probably already happening.
Yeah.
We just don't get all the information.
Yeah, and it'd be interesting just to hear the stats of that,
Yeah.
So the stats are getting worse. The figures are getting worse. This last quarter has been the worst quarter on record. And I think we were going to suggest writing. I think Linda has suggested writing to the department, and I think we should take Diane's suggestion of asking the officials who are responsible to come in and answer some of the things.
Can I suggest as well? I don't know whether we've done this in another guise or not, but building on the issue about the back door that we're told about, have we ever asked the department for their actual strategy to deal with the domiciliary care crisis, where they actually write back and say, this is what we're doing today to actually deal with that crisis? Because I don't certainly have a flavour of what they're doing. I know that we talk about it, I know that it's referenced in the chamber, but what actual practical steps are they undertaking at this exact minute in time? Are they working with groups? Are they introducing new training? Are they looking for new ways of stamping down things? Are they looking at new ways of reconfiguring the flow? What are they actually doing? Or is it just that blank page, big discussion that then doesn't fix the problems afterwards? So could we ask for that? Because I think we should build, and we should be more acute in declaring this a domiciliary care emergency.
Yes.
There's an emergency where people go in the front door, but we've got an emergency at the back door as well. And I think unless we declare it that and view it as that, I just don't think there's going to be an urgency about finding a solution to it.
Well, are members happy that we ask the departmental officials who are responsible for this to come in and give us an urgent response to today's briefing and to the report?
I wonder, Chair, I'm sorry if I'm rabbit now, if we often get 4 people up presenting, but what if we had 2 that are dealing with the emergency and 2 that are dealing with domiciliary and at the same time? Because until they realise that the team actually has a direct impact on the other team, and that we can hear what one problem is because another problem isn't being solved, I don't think that there's necessarily going to be that understanding.
Certainly, I think we should be that's the way we should be taking it forward.
That's
so
a good idea. Yeah.
Okay. The other follow-up then was writing to the Chief Medical Officer regarding the letter from Doctors in Distress and any response that they get as well, just that we get a copy of that.
I recall GPs writing to me about, and I think Ursula Mason had an event with Doctors in Distress, and I had assumed it had now started to operate here, but clearly I'm wrong. They don't seem
We had a tree planting in Ursula's surgery that was to do with remembering people that had taken their lives within the service, but it was being organised
by Doctors in Distress. I think they are an organisation. I mean, I do think there's bound to be moral harm and so on. I mean, if you face that, I mean, I've been in emergency departments, and if you face that day in and day out, and you know the impact of the problem, I just think that it would be worthwhile, even writing to them formally and sort of saying, are you operating here? What's the capacity? Just for more information.
Okay, no problem. We'll take that forward then. Yep. Thank you. Okay, folks, we're happy to move on to item 7 on our agenda. The Tobacco and Vapes Act from 2026. So it was a draft AR or a draft SR that was proposed. The department has advised that they have made a number of minor amendments to this commencement order and will lay a new order in the coming days. The committee will consider this at a later meeting once the new order has been laid. So is everybody okay that we move on from that? Okay, thank you. Item number 8 is a written briefing from the department, cancer strategy. So I'm going to refer members to the written briefing on page 50 of your main pack. Has anybody any comments they would like to make on that?
Chair, can I make just a couple of comments?
Yep.
And one is really the funding for the cancer strategy. I noticed that page 54 in this, it says that since 2024-25, 10.6 million has been invested recurrently into the implementation of the cancer strategy. However, the cancer strategy funding plan assumed a recurrent investment of 55.7 million by year 4, rising to 145 million by year 10. It also identifies a capital investment requirement. Is there any assessment anywhere of the impact that has? I mean, it certainly, it must have an impact in terms of waiting lists and waiting times, because we know that those are really, really bad. I'm just wondering if we could just ask a further question about how they've evaluated the lack of funding and, you know, the impact. And could I just also, I think it's also important that we write to the department. When I was talking to the cancer charities that were here on Tuesday, the cancer charity that looked after prostate cancer, I had asked a number of questions on the usage of our, I'm going to say this wrong, arbiterarone, the new cancer drug. You can say it much better, I'm sure. Anyway, and it is available everywhere in the United Kingdom, but not here. In certain cases. So, and I was just wondering, could we actually get an update on what they're actually doing in relation to that, and why it is not available on the same basis as it is available in England, Scotland and Wales?
I think there was an update, actually.
Was there?
The chamber last week, but I don't know if it's widespread. Remember the minister said in his, he said in the chamber last week.
There have been questions, and I think he has given it.
Maybe it was question time. He says it was now. He was pleased to announce it was now available. Don't know the exact wording, but he did reference it.
All right. Well, I'll check that up. But I'm really just waiting until we check that up. It's just that I was asked very specifically about that.
Just to say on that as well, we do have an oral briefing from Cancer Research UK next week.
Oh, well then maybe
particularly around
the
waiting times. So I think that would fit in quite well with that. Orlia?
Yeah, sure. I just wanted to ask you around the issue of ovarian cancer. I know that obviously we've all been working with the lobby groups on this issue, and it's clear that it is one of those silent killers when it comes to cancer in terms of women. And if we could go back to us specifically, if there is any work that's, you know, it might be part of the Women's Health Action Plan, I'm not sure, but on that issue specifically around the ovarian cancer, because the awareness month has just passed. Well, we're still at the end of it now at the minute, but on that specifically, I just worry if there's not enough being done around that, because there's not the signs for women to look out for. It's difficult for women to identify if they have them.
Absolutely, and the more we know about that, the better. So, no, very happy to take that forward. Anybody else on this item? No? Okay, we're going to move on to then a written briefing from the department on the implementation of the Adoption and Children's Act. I'm going to refer members to page 62 of your packs. Can I ask, has anybody any questions on this? No. Okay, folks, just to highlight that this is another phased implementation bill, which I'm sure we'll all be familiar with, and it does seem to be progressing very, very slowly. Are we happy enough just to... No comments need to be made on this? You're happy enough? Just to note. Yep. Okay, folks, we'll move on. Item number 10 then, correspondence. I'm going to refer members to the correspondence in the main pack at page 81 and includes a correspondence index at page 82. Has members any comments about any items within that? Sorry, Aurea? Yeah.
On item 10.3, so it was the Minister's response around the shared care arrangements, the ADHD services, and the issue obviously that we've all been picking up with people who had private arrangements, and then in a lot of instances that's come to an end. And I don't know, just reading the Minister's response, it's confusing me as to where the problem lies here, because the Minister seems to be saying that, you know, that it rests with the individual GP practice, and that it has, yes, became more sort of difficult, you know, with some of the changes that were brought in place. If you remember, we were talking about the amber, some of the medications that were moved onto the amber list, and then that was making GPs maybe more reluctant to continue on with these arrangements. But the Minister is saying, while it's regrettable, my department is not responsible for any arrangements agreed between patients and private providers. And then when I'm dealing with people locally, my constituents, and dealing with GP practices, they're coming back saying, oh, well, we can no longer do this because of the guidance that's set out by the department. So I am not clear where the problem lies. And I know the last time we raised this, we had asked the specific question around, is there any manoeuvre for the department or the Minister to look into this amber list of medications, to maybe give more flexibility or reassurance to GPs if they can continue on with these shared care arrangements? It's just my thoughts, my feedback on reading that letter.
No, certainly it doesn't provide any more clarity, and certainly it does seem to be quite a stubborn issue. Any particular solution, do you think, or?
Well, it's just the issue that I'm picking up seems to be from the GP perspective, from medications that were moved onto the amber list, which includes the medications for ADHD, that they are no longer continuing with the shared care arrangements because they've been moved onto an amber list. So the last time we discussed this, I'm almost sure at the Health Committee, I think I had mentioned about, well, can we probe into that a wee bit more with the Minister? Yeah. Does the department have any wriggle room to allow more flexibility, you know, for GPs to continue with these arrangements, even for those medications that are on the amber list?
So, as a suggestion, to write to the department and ask about flexibility for GPs to prescribe amber list drugs?
Yes.
Okay. Happy to take that forward. No problem, Anne, thank you.
Yeah, I think that's something we could also raise again. There's an APG, and I chaired the APG on general practice with GPs, and I think it actually is something that we could add to the agenda to discuss with the GPs there, because I know that when we met with them before, there was strict governance and regulation rules about prescribing amber alert with or amber coded drugs, without having like the care over the patient. So I don't think that I think they'd probably be very reluctant to start being able to prescribe those.
Okay.
But it leaves parents and adults and just stuck in the middle of like paying for private diagnosis from private providers that know fine rightly they're not going to be getting their medication.
And sure, just on this specific medication, because we're specifically talking about the medication that people were receiving for ADHD. So in the meantime, when there's no commission service across any trust, people then had these arrangements in place with their GPs for a long time. You know, some people for a very long time, and these medications are keeping them, you know, healthy and protecting their well-being. And so now, because they've moved on to the amber list, that this change has come about where GPs are saying we can no longer do it because they're obviously following the guidelines, the regulation, and then when the Minister's coming back saying what's nothing to do with his department.
And it's forcing a lot of people to go private, and I'm sure we all know people in our constituencies that are being forced down the private route to get medication that they need to stay well, which I think is wrong. So very happy to write to the department on the back of that. I want to just draw members' attention to correspondence item 10.4, I think it is. It's the departmental response to the programme for government and the delivery unit.
Yes.
Now, there's some quite surprising figures in here. It would appear that for the waiting list initiative and the backlog clearance, there has been quite a lot of spend, and the majority of it appears to be in the independent sector in both cases. But it would appear to be less activity within that spend than there is in the Department of Health spend. So I was going to suggest, this is for discussion, so I was going to suggest that we actually write and request a breakdown of the activity that is mentioned here, because it obviously doesn't give us anything to compare what procedures are being done, and to see if there's if we can get the cost for each procedure within the independent sector and within the health service, to see if we can make a comparison. Would members be happy enough we take that forward?
Yeah, absolutely.
Yeah.
I should have known.
Okay, folks. Just in other items of correspondence, is there anything else anybody would like to refer to?
Yes.
Diane?
So 10.5, where we have a response back from the trust, very belated response back from the trust on issues in relation to the handover of the maternity hospital. And it's really the first one which was got me a little bit, which was that really they didn't know what we were talking about in terms of the BISRA report. This report was an audit done at handover, and the 20th of February 2025, the project handover information for the new maternity hospital project found that there was only a 30% alignment with industry published guidelines, and that 45% of the folders containing the required information were missing. So this was an important report that was used to guide the handover of the Royal Maternity Hospital. And it's a bit disingenuous how they've replied in the response to the committee. I would like us to go back to the trust and say, what happened to the missing papers?
Why?
What was in the missing papers? Why did nobody seek to have the missing papers? Because if they're now going to have another review and half of the stuff is missing, what are they reviewing?
Oh, absolutely, and very happy to follow that up then as well. So your suggestion is that we write to the department?
This came from the trust. The letter was from Brona Dalzell, who's just connecting with us again. So it probably really just needs to go to the chief executive of the trust again, you know. And it was the trust. I mean, there is also some reason to sort of question 476 of 529 outlets were sampled during the construction period prior to handover, so a significant number weren't. But sampling undertaken in February 2024 for handover purposes was limited to high-risk clinical areas, primarily the neonatal unit. 117 sample points were tested as part of the handover process. So 117 in February out of 529 were actually tested.
What's happened to the rest?
Why did we only test one section according to their letter? You know, and they accept that, they seem to accept in their letter that Pseudomonas was present, but the result were assessed as falling within the requirements, and I'm quoting of the contract. the decision making around this is really very, very strange.
In terms of what we're asking of the Trust, are we asking for specific things?
Certainly, I would ask about the report, about the missing information. What on earth, if we are going to have someone who's going to review this handover process, how are they going to review it if this sort of information is missing? Can we have also an up-to-date on who is doing this review, when this review will start, and when, importantly, this review will finish, so that we don't have an open-ended process?
I think we've been promised the review would come to committee as well.
Yes.
One thing I would add to it is the range, that there is a range that is accepted within the contract. I wonder if we just could ask some questions around that.
Yes, no, I think that's right. So it's
because otherwise I might have missed the point here, but they're saying we've asked about missing reports. They've come back and said, can you give us more information about what is it you're looking for? You're able to tell us exactly how many pieces of information we're missing, and I would suggest that the missing pieces are the bit that aren't there. So I can't understand why they have to come back and ask what it is. It's dead easy. If you've got 500 pieces of information and you've only got 400 in front of you, it's the 100 that's missing that we're asking about. But it just feels like, from a governance perspective, if Diane's able to know how many pieces are missing but they're not able to tell us, there's something that ain't right in there with respect to Diane, and well done for finding that out. But that speaks to a much bigger issue if they're trying to, I'm going to use that big word I can never pronounce, obfuscate, by asking, which bits of missing information are you looking for? Well, if we've been able to find out which bits are missing without having to ask them, and they're just coming back and asking, it feels like they're just playing us.
Well, I wouldn't like to think they were doing that, but like I think this, I mean, I have a view on this, and maybe I've been just involved with it for so long, that this will require some kind of inquiry to actually uncover the issues around it. And I have said both publicly and in private to the Belfast Trust that I thought that this further review, I didn't know the point of it, and so on. But I'd really want to know, have they now settled on who is going to do the review? Because they couldn't tell it. They came and announced a review but didn't have any details of the review. And when's it going to start, and importantly, when's it going to finish, so that we don't have an open-ended process. I met the Royal College of Midwives this week, and they were going yesterday. I'm going to say I met them on Tuesday. All the days melt into each other. So they were going this week to talk to the Belfast Trust about the building, and I think the Belfast Trust are quite keen to get some responses from bodies about early occupation of the building, and I don't know, I just think that a lot of what was said was to get the committee meeting over and done with. It felt like that to me.
I think the Minister has referred to that a couple of times himself, that we would be trying to use the building as early as possible, but I don't think there's been any clarity.
There's no information on it whatsoever, and it was confirmed. I mean, I was talking to the senior leadership team in the Royal College, and they were saying they were only going to throw about ideas with them or hear what they had to say. So I don't think there's any real progress on that at all, from what I can gather.
We'll certainly write.
Sorry, that's an absolute essay for you. Apologies.
And it's just on the last point there around the early occupation of the site. So they've said in the letter that they sent to the committee that the Trust Board was actually receiving a presentation today on the water remediation. It's the stage 1 report or something they're calling it. So on the remediation work. So just if we can add into the letter then, is that going to provide us with any dates or timelines, or if we can get that information as soon as possible around, it will go to the Minister obviously too, and the updates will come through to us, but just to make the point, the sooner we can get that the better. So there might be a shed of light somewhere in this whole fiasco to get people into the building safely.
Absolutely. I think it's right that committee sees that as well. So, Nuala?
It's on the same item correspondence, but a different issue in the letter.
Okay.
We have a letter here that says, I asked a question specifically about what work had been undertaken for sourcing residential or respite provision places in Belfast, in particular from the Trust. And they have said here they have undertaken a feasibility study for the use of Pine Lodge for self-contained apartments for both residential and service. Residential and respite, but that it's subject to review, but also necessary funding required to refurbish the facility. And the 13 million that was committed to respite, I understand was not capital, but surely all of the refurbishment isn't necessarily all capital, but also there begs the question that if they knew from the very beginning that they didn't have enough facilities, surely it should not just all have been resource, so that they can use it. And we know that they have not used the first year's money. So I think it's worth getting more detail from the department on the money that wasn't spent at the 13 million and whether any additional capital money will be committed for respite. It seems that I read this and I thought, I think maybe there might be a little bit of a hope that we don't read our papers properly, but we know money wasn't spent. We know money was committed every year. And they knew at the beginning that they needed more capital.
Respite briefing from the department in 2 weeks.
Oh, great. Well, then maybe we can wait till then and just.
Okay, folks. Outside of that, are members happy with the suggested actions then, as well as the ones we've discussed? Yep. Okay, moving on to item 11, our forward work programme. Just to refer members to the draft forward work programme at page 147. Are members content with the draft forward work programme?
Yeah.
Yep. And to remind members, just have a couple of things coming up. The committee is going on a visit to London on the 2nd of the 3rd of June with the Permanent Secretary to meet with primary care leaders and to examine England's model for the delivery of primary care. And to also remind members that the Mental Health Champion and the Health Committee joint event is on Thursday the 4th of June from 9:30am to 12:30am. It is a Health Committee event and members' attendance would be appreciated. Can you please get in touch with committee staff and let them know if you will be attending?
Chair, just to put it on the record, I'll have police on board that morning.
I'll have police on board as well, and so will Alan, and so will
Linda,
unfortunately. And
anyone else? No, I've got.
I hope to get for about an hour, but I have a pre-arranged visit with 6 individuals and I really can't cancel now.
No problem. And also then just to advise members that the committee has arranged to take oral evidence from the mothers of the I'm Not OK Spotlight campaign in a formal meeting on Tuesday the 30th of June at 10am. Okay. Okay folks, moving on to any other business. Diane.
Yeah, so going back to my meeting with the Royal College of Midwives, they are very concerned about staffing, about the lack of a strategy and the lack of implementation around the Renfrew report. So I think maybe initially if we could write to the department, that would be, and ask about those issues. And can I just sort of say everything about 2 other issues? The issue of safe staffing legislation. I mean, it's absolutely gobsmacking that the Royal College of Emergency Medicine has not ever been consulted in relation to safer staffing. So could we just write and ask who is being consulted? Yeah. You know, and can we have a list?
Yeah.
Because that
it's like the reconfiguration all over again.
But it's sort of like that is quite the placard.
Yeah.
Whatever happened to it as well, but it is actually quite shocking that safer staffing in our given the report and the number of excess deaths it's shocking that that's where we are in relation to that. And I suppose the last thing I wanted to mention was I was hearing earlier in the week, and I hope I'm right in this, that the 18th of June will be the publication date for the Muckamore inquiry. And I was just wondering how we will get that conveyed to us.
Sorry, I'm just going to come in on that now. That was another item I should have raised. Apologies. Just within the Forward Work Programme, the committee has received confirmation that Muckamore Abbey Hospital Inquiry Report will be published on the 18th of June. We will look to schedule a briefing with the chair as soon as the inquiry, the chair of the inquiry, soon after publication, and this may be a Zoom meeting, but the date will be confirmed. Apologies, I should have.
It's just that is going to be huge. I think.
Yeah.
Okay.
I think we should try to.
So just with Diane's, the safe staffing legislation and the Royal College of Midwives,
right to the department on that.
And certainly, I think we've met with Royal College of Midwives, who
Standard,
highlighted the same issues to ourselves, and certainly would be of the same mind. Anyone else? Colin?
Yeah. Chair, as we'll all be aware, this place doesn't have a budget, and obviously that means there's going to be, as it continues on, there will be constraints on the spending that the department can do as it does its forward planning. Could we write to the department and ask them what contingencies they are planning in the absence of a budget and the restrictions that it will place on their spending? And are there any projects, or are there any initiatives, or any work that is being stalled currently because they don't have the confirmation of the budget? And is there been any communication to arm's length bodies in the community and voluntary sector that receive funding to ask them to prepare for the fact that there may not be a full budget? Because it's June next week, we'll be 2 months and a 12-month period, and we don't have a budget set, and it's just not acceptable. And there will be ramifications on the ground for bodies, but we just need to find out if the department is preparing for that.
Yep. Absolutely. Yeah. Happy enough to do that, everyone?
Yep.
Content. Anybody else? Any AOE? Oh, okay. Item 13, date, time and place of our next meeting. The next formal committee meeting is room 29, Thursday the 4th of June at 2 p.m. Meeting adjourned. Thank you, everybody.
Thank you, Chair.
6 minutes past.
Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound.